well, I'm being here for the first time, students. Let me introduce myself. I'm Dr. Tapas Chatterjee, as Sanjay has told, and I'm a practicing neurosurgeon in Calcutta. I was trained in Calcutta and England, and I do neurosurgery, as you know, surgery for the brain and spine and nerves, very nerve-wracking and a demanding subject, to tell the least. So, can you hear me, students?
Yes,
can you hear me? Okay, right. So, as far as I recollect, when I was doing my MS, I think most of your students are MS or DNB or both.
sir.
Your students are doing MS or DNB, is it?
Principally DNB, I think. Tapas, some
okay.
MS also.
So basically, I think there will be a paper on one paper on special subjects like neurosurgery and plastic, and I'll take you through a bit of neurosurgery, if that's okay with you. Okay, so basically, the first thing that's very relevant, the one thing that is very relevant in neurosurgery is to know. Today we'll be discussing on head injury. Head injury is one of those parameters of surgical which demands a lot of stress from the doctor, because it's something which happens suddenly out of the blue, and its outcomes are at many instances quite dismal, especially if people are unaware of what exactly to be done and what exactly is to be seen. So any degree of traumatic brain injury, ranging from scalp laceration to LOC to focal neurological deficits, all can be head injury. And as the Greek philosopher had once said, that no head injury is too big to be despaired and too small to be despised. So as a senior doctor, I'll advise you that never take head injuries lightly, and never say that nothing has happened. If you have the slightest of doubt, the threshold should be very low. If you have the slightest of doubt, you take advice of a senior, or you do a CT scan, or you overtreat. I don't mind you overtreat head injury, because if you lose the small things, subtle things which are to be noted, the patient can die, really. The patient can die. So, as I told you, head injuries can be disastrous. And the other thing about head injury is that it affects prime of life. It affects people, young people, people in their 20s and 30s, especially in India, with road traffic accidents being very common. And then there are falls and other domestic accidents. But road traffic accidents are the commonest cause of head injury. Any questions till now? Anyone has anything to ask, or I'll move forward? Is it okay?
Yes, sir.
Okay. So I think you know this thing. So what are the causes? It might be a bit boring, but you should know that in India, the most important cause, obviously, is motor vehicle accidents. If you see head injuries maybe 30, 40 years back, the commonest causes were falls and assaults and other related injuries. But now motor vehicle accidents are the commonest cause. And you should remember that here the injury is a high velocity injury. What is important in head injury is what type of injury, whether it's a high velocity or a low velocity. And motor vehicle accidents are high velocity injuries, which can cause a lot of disruption. And before I go any further, let me tell you that whenever you are asked to assess a person of head injury, the first and the foremost thing that is, unlike in other surgical emergencies, maybe, that the patient usually cannot give a history. So it's very important for you to take the history from passers-by, from people who had seen the patient. So the patient can never give history. The patient can never give history in instances because he's unconscious. So I told you motor vehicle accidents, falls, assaults, sports-related injuries, and fire-related injuries are the common cause of head injuries. Okay. Now, why is head injury important, or is given so much of significance in society? Because the high potential poor outcome. Even today, head injuries have a very poor outcome in many instances. When we see later, when we classify head injuries into mild, moderate, and severe on the Glasgow Coma scale, we find that head injuries have a high potential for poor outcome. We'll come to know why it is so. Deaths occur at 3 points in time after injury. Immediately after the injury, which you have nothing to do, a massive injury, a massive injury to the brain and the brainstem. Within 2 hours after injury, that is a golden period, and 3 weeks after injury. Now, there is a dictum amongst neurosurgeons that if you can survive a patient for at least 3 weeks, or maybe 4 weeks with head injury, the patient usually does not die of head injury. He dies of other causes. He dies of things like infection. He dies of things like a deep vein thrombosis and pulmonary embolism. He might die of chest infection. He may die of bleeding ulcers. So these things are potentially preventable. So as I always tell to my students, that head injury is something where each and every factor is very important. It is just not enough that you do a brilliant surgery, you do a fantastic, you take out the clot and you do a fantastic surgery. That's only maybe 1/3 of the work done. What is important is to see the minor points of nutrition. Is a patient having adequate prophylaxis of the lower veins? That's very, very important. These people are immobile. These people cannot move. And there's a very, very high chance of a potentially fatal pulmonary thromboembolism. So that's very important, and that's something which can be prevented. Just you have to be aware of it, that this patient can embolism. Chest physiotherapy is very important because these people are on a ventilator, and it's important that you see that the chest is not the source of potential infection or atelectasis. Physiotherapy to keep the limbs mobile. As I tell you that after there's a head injury, what happens is that the muscles in the body and everything is fine. It is only the head and the spinal cord which is not working. So you should keep your body in a perfectly fit position so that when the brain starts to come back, it gets a proper muscle, proper tissue to function. If you don't look after these things, if the patient goes into some form of atrophy or contracture in the period when you're treating head injury, even when the patient comes back and tries to move his arms or legs, he might have an atrophy, he might have a contracture. So it's very important to keep the patient mobile. So it's simple measures like doing a regular physiotherapy of the lower limbs and upper limbs, doing a prophylaxis of deep vein thrombosis. In head injury, obviously, it is better to go on with the mechanical prophylaxis because in many instances, there is blood in the brain. So we don't go for chemical prophylaxis. So you go for these dead stockings or the pneumatic compression stockings. And simple measures like changing posture of the patient from right to left every 1 or 2 hours to prevent a bed sore. And then proper nutrition to see that there's no infection of the urine, there's no infection from the long line or the things that like the IV. So these are very small things which tilt the favor in favor of you saving a patient or not. As I tell you, you do a brilliant surgery, you do a fantastic surgery, and you don't see all these things when the patient dies. On the contrary, your surgery may not be that great, but you see all the small things and actually the patient survives. It's all about the small things which ultimately is important for the patient to survive. Is that clear? Can you follow me? I want some response from you because then I'm thinking I'm just talking to my yeah, so there should be some response. There should be some mumbling somewhere so that I know that I'm speaking to people who are listening. Okay. Any questions till now? Any questions? You are free. We are just discussing. I'm not your teacher in the way. If you have any questions to ask me, you can ask me now. Is that fine?
Yes, sir.
Okay. So you understand that it's very important for the small nitty-gritty things in head injury. It's very important. I tell that because we'll go deep into head injury later, but these small things actually make all the difference from you successfully treating a patient or not. As in other, like in other things, here the patient is unconscious. It's just like a baby, and you have to see every small thing: nutrition, prophylaxis, bed sore prevention, prevention of infection, chest physiotherapy, and everything, even endotracheal and the things endotracheal suction, and when to do a tracheostomy. I'll go later. So these things important, along with a proper surgical procedure as it may warrant in the case of head injury. So types of head injury is you just start from the scalp and you go inside. As I tell you, you start from the scalp, and the scalp has 5 layers, as you know, and it can be an injury in the scalp, which is called a scalp hematoma, and then there can be a skull fracture, which is the skull. We'll go to fractures. The fractures can be various types, but for now, just remember there can be a skull fracture. And then it goes inside. There's a minor head trauma, concussion, and post-concussion syndrome. Where here, what happens is exactly, if you do a CT scan with a patient who has a concussion, you don't find anything. It's like the head has been shaken, really, and the patient was certainly unconscious for some time, and then he comes back. So there is no anatomical change in the CT scan. But if you go for a physiological, then you can find that there's some disruption in the neurons in the brain. It's called diffuse axon injury. And there's a major head trauma which can cause cerebral contusion and laceration. Till now, remember that if the head injury looks devastating outside, probably the patient's brain is saved. It's very important. He might have a terrible laceration. He might have the eyes blown out and bleeding, and the patient is talking. We have seen this. Contrarily, if a patient is absolutely fine, there's no external injury, the whole brunt of the shock has gone inside the brain into the parenchyma and the brainstem, and the patient is deeply unconscious, and the prognosis can be dismal. So if you see a head injury patient with very severe lacerations and bleeding, don't get scared. I think that patient has a better chance to live than a patient who has head injury who looks absolutely perfect. The other important thing, please remember, if some of you ever become a neurosurgeon, or even if you don't become, if there's a skull fracture, I think probably it's good, really. We have seen that people have skull fracture, the amount of force which needs to break the skull actually prevents further injury inside the brain. What is important is to prevent injury to the brain parenchyma and the brainstem. You have heard of the brainstem? Have you heard of the brainstem?
Yes, sir.
Yes, the three parts of the brainstem, midbrain, pons, and medulla. That is the most important part of the human brain. The brainstem, which controls the reflexes, which controls the breathing, which controls the reticular activating system, and the brain parenchyma, which actually is the cortical functions. So at this point, remember that if there's an injury to the brainstem, that is devastating. If injury to the cortex, that is also devastating. But the injury to the brainstem is more devastating. Please remember, never use two terms loosely. One is a persistent vegetative state, and the other is a brainstem death. Anyone knows what is the difference between a persistent vegetative state and a brainstem brain death when you go for organ transplantation? Anyone has any idea? I will tell you.
Yes.
Yes. So always remember that whenever we talk of brain death, have you heard of brain death? People having organ transplantations and brain death. Have you heard of the term brain death?
Yes. Yes, sir.
Yes.
Yes.
Brain death means brainstem death. Okay, brainstem death. There are 6 or 7 reflexes which are controlled by the brainstem, the life-giving reflexes. And if that is shut, the patient dies. And it has been seen that if there's a brainstem death, the heart is pumping, the patient normally dies within 2 or 3. And there has never been any anecdotal or any reason to believe that there has been an exception to this. If you do a brainstem death, if you do properly, if you know the reflexes to be seen, and if you qualify the patient to be brain death, it is as good as death. And then you can actually go for organ transplantation because the patient is not going to come back. What is a persistent vegetative state? Here the brainstem is functioning. The brainstem is functioning. The cortex, you know, the huge cortex and the sulci and gyri, the person where the cognitive functions and our psyche and the personality and all the motor functions we do. If that is injured, then the patient is in a persistent vegetative state. He is breathing, he can be fed, he has all his reflexes intact, but he doesn't have his personality. It's gone. He doesn't need, he is not in a ventilator, he is not brain dead, his organs can't be transplanted, he is a living person, but he is absolutely, he has no cognitive or personality. The part of the brain which controls this is the outer parenchyma, the sulci and gyri, the temporal lobe and the frontal lobe and the parietal lobe and the occipital lobe. And the patient cannot speak or he can't shed an emotion, but actually he's breathing himself, he is swallowing himself, he has his pupillary reflexes, he has his oculocephalic reflexes, all the reflexes are intact. So that is what is called a persistent vegetative state. Patient can never go for organ transplant there, but if a patient is brain dead, patient is on a ventilator, he's being artificially pumped in oxygen because his respiration stopped, his heart is pumping, the organs are fine, he is going to die within 2 or 3 weeks, or 2 or 3 days, sorry. You are in a position to harvest his organs, provided it is good enough, and transplant. So that is the difference between a brain death patient and a persistent vegetative state. Is that clear to you? Is that clear?
Sir.
Any questions? Any questions?
Hello.
So when we go for a brain death, please remember there are certain important reflexes which we should know. So there are 6 or 7 reflexes which should be absent to confirm a person is brain dead. The first and foremost, very important, is the pupils are fixed and dilated, not reacting to light. Okay, the pupils are fixed, dilated, not reacting to light. That is the first reflex. That is very important. That's a very, very ominous reflex. The second reflex is called the hello. Hello.
So sorry to interrupt, sir. This is Shilajit, sir. Sir, the slides are not changing, sir.
Yeah, I actually I'm keeping to the head injury point. I'm actually speaking on that. I will change the slide later. I'm just talking of it. Okay, I'll just talk of it.
Okay, sir. Okay. Thank you, sir.
I'm just telling you about what is the brain death here, because I'll come to you later. So basically, the reflex of pupils fixed and dilated, not reacting to light. Ocular cephalic reflex is gone. There is a reflex called the doll's eye, which I'll tell you later. Ocular vestro reflex. So when you pump in water through your ears, then there is a nystagmus. The gag reflex, swallowing reflex is lost. There's no movement on painful stimuli. And the last is that there's apnea. Because once the ventilator is cut off, when the carbon dioxide raised in the blood, it is a very potent stimulation. Okay, it is a very potent stimulator. But even then the patient doesn't breathe. So that's called the apnea test positive. And then you confirm the patient to be brain dead. Anyway, we'll come to that later. Next slide is, what is a scalp laceration? The most minor type of head trauma. Scalp is highly vascular. You know how many layers are there in the scalp? Anyone has any idea how many layers?
5 layers, sir.
5 layers. Very good. So S stands for skin, then connective tissue, then aponeurotica, loose periosteal tissue, and periosteum. Okay, SCALP. All right. So it's a very vascular part of the head. And here what we do is that you go for compression and you go for stitches. The stitches that you give on scalp lacerations are usually mattress stitches, because if you just give simple stitches, there's a chance that hematoma can increase. So, and scalp lacerations are very prone to infection because of the blood that is collected there. All right. Okay. Now coming to skull fractures. So these are the various skull fractures. A linear skull fracture, as you know, is any fracture which is in any particular distance, a long fracture. A depressed skull fracture. Anyone has any idea what is a depressed skull fracture? Anyone has any idea what is a depressed skull fracture? Have you heard the terms depressed skull fracture?
With the instrument, hammer and...
Yeah. It's not about, it can be done with anything, hammer and everything. A depressed skull fracture is when the outer table of one fragment is below the inner table of the other. Please remember this for the rest of your life. When the bone has 2 tables, the outer table and the inner table. When the outer table goes below the level of the inner table, other fragment, that is called a depressed fracture. Do you understand what I mean? So if there's a blow on the hammer, the outer table of one part goes so deep inside the brain that actually it is at the level of the inner table of the adjoining part of the brain. That's called a depressed skull fracture. Okay, so depressed skull fractures basically are the ones which take in a lot of energy for the skull to be depressed, and people are remarkably conscious after depressed skull fracture. People are in fact talking after depressed skull fracture. And here what we do is that we elevate the depressed segment and try to put it back. Sometimes we cannot, then we just get rid of the depressed segment, and then later we put on some artificial mesh in the form of titanium or other calcium products. So that is the way the depressed skull fracture. What's the diastatic skull fracture? Diastatic skull fractures are fractures which happen in the sutures, during the sutures of the brain, the sagittal suture, the parietal sutures. You know the sutures in the brain? If there's a fracture there, it's called a diastatic skull fracture. Basal skull fractures are skull fractures which occurs at the base of the brain. You know, the brain, the cranium is 3 fossa: anterior cranial fossa, middle cranial fossa, and the posterior cranial fossa. And where the brain sits, on the part of the bone where the brain sits, that part, if there's a fracture at that part, it's called a basal skull fracture. We know the significance of basal skull fractures. That can cause 2 important significance. It can cause CSF discharge from the nose. You know what is called CSF rhinorrhea. It can cause CSF discharge from the ear. It's called CSF otorrhea. So whenever you find a patient with a head injury, there's some bleeding from the ears, there's a bleeding from the nose, there's some watery discharge, please keep in mind that the patient might have what is called a basal skull fracture, the skull fracture at the base of the brain. Compound skull fractures, as students of surgery should know, compound skull fractures, are the ones where there's a broken break in the skin and the fracture segment is coming out. These parts have to be debrided very quickly. You have to go in for surgery, excise the part of the bone which cannot be put back, and thorough cleaning with hydrogen peroxide and other antiseptics, and then you should close it, because compound skull fractures are potentially notorious for being a source of infection for inside the brain. It can cause meningitis. A compound elevated skull fracture is similar to a compound skull fracture, except for the fact that the fracture segments have all come out and it's sticking out of the bone. And a growing skull fracture. Students, are you hearing me?
Yes, sir.
Please remember that the growing skull fracture is a question that might be asked to you in your DNB questions. So do you have any idea what is a growing skull fracture? Let me see. What is your opinion? What do you think? What's a growing skull fracture? Any idea?
And kids.
You need tips.
A pond fracture.
No, remember, as a thing, it is not as simple as a fracture which is growing. What happens is that sometimes, remember that when there is a fracture over the skull and there is tear inside the dura, the dura is torn, all right? So there's pulsation, there's a pulsation of the arachnoid and the brain inside the dura, and it never allows the fracture segments to heal. So there's a fracture, below there's a torn in the dura, and below the dura, there is pulsation of the brain which is sticking out from the dura and prevents the two edges of the skull bones to unite. That is called a growing skull fracture, and that is very common in children. So there's a fracture, and there should be a tear in the dura, and the dural pulsation prevents the two fracture ends from uniting, because there's a brain pulsation which is pulsating between the two fracture ends. Is that clear? So that is called a growing skull fracture. There's a short note. It can be asked in DNB. It can be asked in any of your entrance examinations if you go further. It's something which is to be known. A growing skull fracture, I repeat again, is not a fracture which is growing, but a fracture with the underlying dural injury, and the arachnoid and the brain pulses through the dura, preventing the two edges of the fracture from ever uniting. And the fracture, rather than uniting, it grows further apart, and that's called a growing skull fracture, and that's very common amongst children. All right. Okay?
Yes, sir.
Good. So skull fractures is very important that location of fracture alters the presentation of the manifestations and facial paralysis. Do you know which nerve is the facial nerve amongst the cranial nerves? Seventh nerve. And what's the function of the facial nerve?
Facial muscle supply motor.
Yes, it is a muscle of facial expression. It is a muscle of facial expression, but it has also some special part to
sensory taste.
Taste, exactly, taste. It has a sensory taste, a special, not sensory taste to the tongue, and it has a small twig to the stapedius in the ear. So these are the main functions of facial nerve. So facial nerve is basically muscles of facial expression, which includes the orbicularis oris, oculi, and then the buccinator and the platysma. It is a special sensation of the taste, and it's also a muscle, a nerve which supplies the stapedius for it helps in hearing. So these are 3 or 4 functions of the facial nerve, and that nerve can be injured very often in a skull fracture. And do you know the type of paralysis the facial nerve will get? Is it an upper motor neuron or a lower motor neuron? What type of fracture, skull fracture and facial paralysis would take? Upper motor? Lower motor, exactly, because it is coming out from the temporal bone, and it will lead to a lower motor type of facial injury. So in that, the whole particular side of the ipsilateral face is affected. Ipsilateral face is affected. You can't look up, you can't shrug, you can't look up, you can't close your eyes properly. So when there is inability to close your eyes properly, what is that term called? Do you have any idea what is the term called?
Bell's phenomenon.
Bell's phenomenon.
It is not Bell's phenomenon. Bell's phenomena is a condition where the facial nerve is injured or due to trauma or due to a virus, and then whenever you try to close your eyes, your eyeball rolls up. That is a base. But if you ask someone to close a person's eyes and then he can't close it properly, that is called a lag of thalmus. Lag of thalmus. Okay. So you ask the patient to squeeze his eyes and you try to raise the eyebrow. If the patient's facial nerve is intact, you won't be able to do it. But normally, if the facial is not intact, the eyebrow will be lifted up by your finger. Or even then, sometimes it can't be closed properly and there's a facial ulcers. So that is called lag of thalmus. In contrast to ptosis, ptosis is different. It's from the third nerve. Lag of thalmus is inability to close your eyes properly. Lag of thalmus, all right. And ptosis is from the third nerve where there's drooping of the eyelids. That's different. That's different. Conjugate deviation of gaze, it can cause various conjugate deviation. You can see on the right side or the left side. And two important signs, which is important, is called the battle sign and raccoon sign. This is the base of the skull fracture. So here, can you see the picture?
Yes, sir.
Yes, so this is called, if you see a patient with a head injury and there's a bruise behind the ear, that is called battle sign. And that has nothing to do with any battle. It actually is named after a British surgeon called E.M. Battle. He found that when the middle cranial fossa is injured and there's bleeding, there's what is called this bleeding inside the posterior part of the ear. That's called battle sign. The other is called raccoons. I don't have the picture. So, and the raccoon size is like there's bruise all around your eyes, like the animal raccoon, and that signifies fracture at the anterior cranial fossa, and both eyes look like raccoons. So that signifies, if you see a patient with raccoon size, it signifies the patient has what is called anterior cranial fossa injury, and battle signs it signifies a middle cranial fossa injury. So the other thing that I told you is about the Csf leak, and please remember that Csf leak can be very notorious, very, very difficult to treat Csf leak. You know what Csf, where is the Csf formed in the brain? Anyone?
Ventricle.
Where is it formed?
Choroid plexus.
Choroid plexus.
Choroid, absolutely. It's formed in the choroid plexus, and it actually goes inside the ventricles, and via the fourth ventricle to the foramen magnum and Lashka, it goes to the basal systems, and then ultimately it's reabsorbed in the venous system. That's where the CSF circulates. And now if there's a fracture and there's a bleeding from the nose and some water comes out, then you have to know whether it is a CSF or not. And the pathognomonic test, if you have pen and paper, please write it down and never forget in the rest of your life. The pathognomonic test to know whether the fluid that's coming out from your ear or your nose is CSF is when you find a protein called beta-2 transferrin. Just write it down. Beta-2 it'll help you all your life. It will come in all your entrance. It will come if you want to do further studies in neuro or any other entrance. What is the pathognomonic protein found in CSF, which can tell me that this was CSF and not tears. It can well be tears coming out. It can be other fluids. So if I want to know whether it is CSF, the pathognomonic protein that can be measured is called beta-2 transferrin. Is that clear? Beta-2 transferrin. All right?
Yes, sir.
Hello? Yeah, right. Beta-2 transferrin is the pathognomonic protein which comes out in CSF. And if you find that in the fluid that you have collected, then you can be sure that the person is having a CSF leak. A CSF leak is dangerous because it is a direct source of infection inside the brain. It can go inside the ventricles. So you have to stop a CSF leak. Earlier days, CSF leak extravasation into ear, otorrhea or nose, rhinorrhea. High risk infection and meningitis. Halo sign is that there's some blood and there is a small halo sign in a white tissue paper. But these things are not important anymore. You go for a beta-2 transferrin test. If the test is positive, it is CSF. If it's not positive, it's not CSF. All right. Investigation. Before I go to investigations, anyone has any idea what is the Glasgow Coma scale? Have you heard the word Glasgow Coma scale?
Yes, sir.
So, what are the 3 parameters of a Glasgow Coma scale? Just one of you tell me. One of you.
Eye opening, verbal response, and motor response.
Yes. So I'll just tell you. Just write it down because I don't know whether I can write it here. So it is basically EVM. Okay. Can you see it?
Yes, sir.
Okay. So eye opening has 4 points. So E has 1, E2, E3, E4. E4 is when a person is oriented to space or time. All right. E3 is when a person is opening his eyes but not oriented to space or time. E2 is when the person is responding to pain, just opening the eyes. And E1 means there is no response. So the maximum you can get is E4 and the minimum you can get is E1. All right?
Sir.
Okay. Similarly, the verbal response has 5 points. V1, V2, V3, V4, V5. V5 is a person is speaking rationally. So if someone asks your name, what is your name? My name is such and such. Where are you? I'm in maybe here in Calcutta or in Bombay or some other, and this is morning. V4 is a person is speaking. He's speaking. Please recollect the difference between V4 and V5. V4 is a person speaking adequately well, but he's confused. He might be saying that I am in my home, or I am in a hospital, or I am, this is day. But he's speaking correctly. He might be speaking his name correctly. He might be saying his son's name correctly. So he's confused. So that is V4. V3 is very important. He's saying a few words, specific words he's saying. Like, don't disturb me. Don't do this. V2 is making a few sounds and V1 is making nothing. So the maximum that can be is V5 when he's speaking very relevantly. V4 is confused. V3, few words. It should be specific words. V2 is sounds and V1 is not. So maximum is V5 and minimum is V1. So a person can have be E1, V1, or he can be E2, V2, or he can be E3, V2. Any combination is possible. So basically, and the last and the most important is the motor response. Motor response is M1, M2, M3, M4, M5, M6. So you see, E has E1, 2, 3, 4, V has 5, and M has 6. What is M6? M6 is a person is obeying commands, obeying commands. Please show me your tongue. Please lift your right finger. Please lift your left leg. He's obeying commands. M5 is localizing. You try to pinch that person, the person takes his finger and pulls it out. So that is localizing to pain. M4 is withdrawal. You try to pinch him, he tries to go away. M3 is abnormal flexion. M2 is abnormal extension. M1 is no response. So the minimum is M1 and the maximum is M6. So a person who has E1, V1, and M1, he is Glasgow Coma Scale 3, severe head injury. 3 to 8 is severe head injury. So 3 to 8 is severe head injury. Okay, all right. Second, if a person has a E3, V3, M5, so how much is this? How much is this? 11, isn't it? Is
Yes,
it
sir.
how much?
Yes, sir.
Is 11.
11.
So from 8 to 13, it is moderate head injury. So below 8 is severe, 8 to 13 is moderate, and 14 and 15 is mild head injury. So you can see very well that the Glasgow Coma Scale is very important for you to understand in what state of consciousness. And please remember, the Glasgow Coma Scale is not a test to see your motor or sensory functions. A person can be completely quadriplegic and yet have a motor response of 6. We are not testing his motor power. What we are testing is his consciousness, his ability for the brain to understand a command and do it. It is not, we are not seeing whether he is having motor power. He can be totally paralyzed from his neck downwards. And even if he sticks out his tongue, he has a motor response of 6. So this is something which is very often mistaken by students. They mistake the motor response as motor power. Motor power is a different modality. Motor response is a different modality. Here you are seeing whether the conscious brain can perform some actions which you want him to do. It is not whether he has the ability to perform, whether he's paraplegic or quadriplegic is not seen. So it is the conscious brain performing a motor act, conscious brain performing a verbal act, and the conscious brain performing eye opening. So the maximum is 15. As you are, I and you are all E4, V5, M6. So we are 15, GCS 15. And the minimum is E1, V1, M1, okay? And the whole gamut of neurosurgery is between this 3 to 15. So it's very important as neurosurgeons or wants to be a doctor, first and foremost, to go to a patient's bedside and find out what is the coma scale. Yes, and you tell to your consultant that I think the patient is E2, he is V3 and M4. And so the patient and the doctor, he might be sitting somewhere in the other part of the town, knows exactly what is the coma scale. So this is important. This important coma score. Hello? Is it okay? Are you hearing?
Yes, sir.
This important coma score, the Glasgow coma score, one of the most important scales ever discovered in modern science, was done by two neurosurgeons and neurologists from Glasgow in 1970s by the name of Teasdale and Jennett. So after the coma scale, it has become mathematically clear that when I say the person is GCS 15 or GCS 13 or GCS 11, you have a fair idea that how bad the head injury is. Earlier, what we said, the patient is unconscious, the patient is subconscious, the patient is comatose, patient is obtunded, and it was very confusing. What is obtunded to me may not be the same to you. What you mean by semi-conscious may be different to what you say and what I think. So this is a mathematical, but when you say that the patient has a coma scale of 10, you know, well, exactly, it's something like this. If someone says a coma scale of 8, you know, it's a severe head injury. So there's no what I want to say, there's no confusion in trying to know how bad the head injury. That's very important. So we go to the bedside of the patient and do the coma scale first. And the other things that is important is the X-ray. I say that even before you do a CT scan, go for an X-ray. In head injury, always remember simple X-ray skull is important to see whether there's a fracture of the skull. And always do X-ray of the cervical spine, X-ray of the chest, X-ray of the pelvis, USG whole abdomen, echocardiography. So it's very important. So when you see a patient who is Glasgow coma scale of 7, you do an X-ray. Hello?
Yes, sir.
Can you hear me?
Yes, sir.
Yeah. So always do an X-ray of the cervical spine. Never ever forget to do X-ray of cervical spine, do a CT scan. Because 10% of people with head injury have severe
Hello?
Hello? Sir, not audible.
Hello?
Hello.
Yes, sir.
Can you hear me?
Yes, sir.
Yes, sir.
Sorry. Hello, you can hear me, eh? Is it
Yes,
clear?
Yes, sir.
Yes, sir.
Yeah, I think there was some something. So we have come. So always remember that whenever you do the investigations, as I tell you, do an X-ray of the cervical spine, a chest, a pelvis, USG whole abdomen, and echocardiography. Because these things can be in a management of head injury, you might miss it. You might miss a splenic rupture. You might miss a long bone fracture. You might miss a cardiac bruise. So always do these along with the CT scan. The CT scan is a standard modality. So whenever you go for a head injury, the one and the most important thing is the CT scan. And when you do a CT scan, you must remember that in head injury, it is not the MRI, but the CT scan that is more helpful. Okay, it is not the MRI, but the CT scan that is more helpful, because the CT scan gives a far better picture for head injuries. And MRI gives a picture better in brain infarctions and brain tumors. So go for a simple CT scan, plain. Do you know what a plain CT scan is? We give no contrast. You just do a CT scan and you see how bad it is. If there's a bleeding from the ear or nose, in case of suspected CSF leak, you go for the transferrin test. And CSF leak, as I told you, is measured by the beta-2 transferrin. All right. Now, pre-hospital care. So it's very important. Patients with severe head injuries should be assumed to have a cervical spine. Never forget that whenever you find a patient with severe head injury, it is very important that you assume that the patient has a bad cervical spine injury also. He might not have. It is nice to be wrong that he never had, but you think that he has it. Never think that the spine is okay, because people have been found to be conscious but paralyzed because he has a bad spinal injury, and immobilized until clinical and radiographic studies can prove otherwise. Always assume every head injury patient to have a cervical spine injury till you prove otherwise. Always assume that this guy has a bad cervical spine injury. Minimize CSF leak by putting the patient blade flat. Never suction orally, because that can actually, if you do a suction orally, it can actually go inside the brain through the fracture inside the brain, because there is a fracture at the base of the skull. And the other thing that is important is the measures to reduce ICP. I'll tell you, supportive management and surgery. So the whole idea of neurosurgery is to lower the intracranial pressure. So minor head trauma, as I told, are concussion, head injury with a temporary loss of brain function. Concussion can cause a variety of physical, cognitive, and emotional symptoms, like cause sudden acceleration, deceleration injury, car accidents, sports injury, bicycle accidents. People have very good recovery. Are you hearing me?
Yes, sir.
Hello?
Yes, sir.
Yeah. People have very good recovery in concussions. You do a CT scan, there's nothing in the CT scan, but the patient has the concussion. That's all a concussion is all about. There is no anatomical damage in the brain, but there's a physiological disruption, which cannot be actually evaluated through any images, but you can evaluate it clinically, and the patient has a good recovery. That's a concussion where there is no bleeding, no contusion, no trauma as such in the brain, which can be seen on an MRI or a CT scan. So that's a concussion where the brain has been shaken. Physiologically, there has been some disruptions, but no anatomical disruptions. Now, head injury, the other thing is that types of head injuries are concussion, as I told, physical headache, they can be loss of consciousness, amnesia, and Cushing's Triad and convulsion. Do you know what the Cushing's Triad is? Anyone, any idea?
Hypertension.
Yes, tell me. Do you know who was Dr. Cushing?
Irregular breathing, bradycardia.
Hypertension, bradycardia.
Yes.
Hypertension, bradycardia, and respiration.
Hypertension, bradycardia, irregular breathing.
And there's two. What's the triad for? What's the third thing for?
Irregular
chance stop breathing.
Hypertension.
Chain stroke.
Hypertension. Hello? Hello? The pressure increases, there's hypertension, there is bradycardia, and there is irregular breathing. This is called a Cushing's Triad. All right. Cushing's Triad. Cushing's Triad. So, hello?
Yes, sir.
Yes, sir.
Is okay? Yeah, that's a Cushing's Triad. So Cushing was, Dr. Cushing, you'll remember Cushing, he's a very, very famous, he's in fact considered to be the father of neurosurgery. He was an American neurosurgeon, and you have the Cushing's Triad, and you have the Cushing syndrome, and you have the Cushing's ulcer. You have a lot of things named after Cushing. He was a very famous American neurosurgeon. And the only other person who's equally famous is Walter Dandy. If you go to neurosurgery, you'll know that. And he is the guy who coined this term Cushing's Triad. And this is a sign that the patient's brain pressure is increasing. The patient's respiration gets irregular, and he's bradycardic, that is, his pulse falls below 60, and there is a high increase of blood pressure. So these were the things which used to be done before the age of CT and MRI, where people could not see inside the brain. But nowadays, you can see the images, and you can put what is called the ICP monitor or a bolt, and you can actually measure the pressure, and you can do accordingly. So head injury, minor head trauma, post-concussion syndrome, 2 weeks to 2 months, persistent headache, lethargy, personality, and behavior changes. These things in minor head trauma, you just need some form of assurance. You don't need anything else. You just need assurance that the patient is fine. Okay. So head injury, major head trauma includes cerebral contusions and lacerations. So it's the bleeding inside the brain, and both injuries represent severe trauma to the brain. So remember that what is the difference between a contusion and a ICH, intracellular bleed? In a contusion, this patchy bleed in the brain with intervening normal neuronal tissue. That's called a contusion. And in an intercerebral bleed, there is blood. There's no intervening brain mat inside. The whole part is filled with blood. That's called the intracerebral hematoma. And if you say there's a contusion, fine patches in the brain of blood with some normal tissue. Is that clear? So that's the difference between a contusion and a ICH. Can you hear me?
Sir.
Yes, yes, okay. The bruising of brain tissue within a focal area that maintains the integrity of the pia, mater, and arachnoid layers associated with multiple microhemorrhages, this is called a contusion. A laceration involves actual tearing of the brain tissue. Intracerebral hemorrhage is generally associated with cerebral laceration. So here I find a CT scan. On the left side, you find which is called the cerebral contusion. If you see the small micro hemorrhages, that's called contusion, because there's intervening brain, and there is also if I point out, just hold on. This is the part. Can you see me? These are the parts of the. These are the parts of the. So there is small brain and there's small whitish part that's called the intervening part. If you see here, there's actually, if you see here, if you see this, the whole part is filled with blood. Can you see the whole part filled with blood? That's called ICH or a laceration. Before that, I must, if you must have a small idea of a CT scan. So can everyone seeing on the monitor the CT scan?
Yes,
So
sir.
if you see, the CT scan is measured in Hounsfield. Have you heard the name Hounsfield? Hounsfield.
Yes, sir.
Yes.
Yes, sir.
So if you see this part, this is the Hounsfield, this is the bone. This part is a bone, okay? This part is a bone. And it has a Hounsfield of plus 1000. That's called bone. This is bone. It's absolutely white. This part is the bone. This is plus 1000. This part is the ventricles. You can see, I'll show you better scans. That is about 0. And the air that is seen inside the sinuses is called minus 1000. So a CT scan ranges from plus 1000, which is the bone, to 0 in the ventricle and air. And this part, which is called the brain parenchyma, is having a Hounsfield of 40. So whenever you read a CT scan, everything is measured according to whether the thing is hyperdense or isodense or hypodense to the brain parenchyma. So here, can you see this white blot here?
Yes, sir.
Can you see the white blot here? So this part is actually hyperdense to the brain parenchyma. So whenever see something which is whiter than the brain parenchyma, that's hyperdense. Whenever see that is blacker, that's called hypodense. And whenever something is equal in density, it's called isodense. That's the way we read CT scans. So whenever we read CT scan, I find a tumor which is hyperdense, which is isodense, or which is hypodense. In MRI, the thing is different. You call intensity. You call something is hyper intense, hypo intense, or iso intense. The same thing. In CT scan, whenever you read, you say it is in accordance to the brain parenchyma. The brain parenchyma is considered to be the standard. Anything which is whiter is hyperdense. Anything which is of the same color, grayish, it is called isodense. And anything which is darker is called hypodense. Is that clear? Is that clear?
Yes, sir.
Good.
Yes, sir.
Yes. So pathophysiology of head injury, there's a term which is called a diffuse axonal injury. It's called a DI. And always remember that whenever you find a CT scan and the patient is unconscious and the CT scan is normal, there's no blood in the brain, but the patient is deeply unconscious. First thing you think is a diffuse axonal injury. So whenever you see a CT scan person brings a CT scan to you and doctor, please see the CT scan. You find the CT scan is perfectly fine. You go to the patient and you find the patient is deeply unconscious. You can't relate it. There's no bleed in the brain. There's nothing. That is a diffuse injury. CT scan looks fine and the patient is deeply unconscious. Then the patient has a diffuse injury. What does it mean? At the micro level, there is micro level tearing of the brain parenchyma and the neurons, which can't be seen anatomically. And the patient is deeply unconscious. There are various grades of diffuse injury, but for students in surgery, remember, diffuse injury is a widespread axonal damage occurring after a mild, moderate, or severe traumatic brain injury. Seen in half the case of head injury, process takes approximately 24 to 24 hours. The CT scan looks remarkably normal, and the patient is remarkably in comatose. There's no blood, there's no subdural, there's no ICH, there's no contusion. The patient is deeply unconscious. You think, you have a hunch, the patient has a diffuse axonal injury. So head injury pathology, what happens is diffuse axonal injury, there's clinical signs, very low level of consciousness. If you put an ICP monitor, the brain pressure is very high. The patient is decerebrating or decortication, global cerebral edema, and 90% regain consciousness from CVDI. They do regain consciousness, but as I told, there are other grades of it, but they do. So again, I come back. A diffuse axonal injury is a condition where there's disruption in the brain parenchyma, which cannot be seen in a CT scan. The patient is deeply unconscious. If you put a monitor, the brain pressure is high. The patient is in various forms of posturing, and the patient does make a recovery, but obviously with some degree of neurodeficits. Now, coming to this important and very important slide is the intracranial hemorrhage. And the two things you students must know is what is an epidural hematoma and what is a subdural hematoma. Epidural hematoma, as you can see, if you see here, this is the epidural hematoma. Hematoma which is on basically between the bone and the dura, epidural. It's called epidural hematoma. So it is basically when you see a hematoma in the scan, which is biconvex. So one part is the convex part of the underlying skull. The other part is the convex part of the underlying dura, and there's a blood there. That is called the epidural hematoma. There is no damage to the brain parenchyma because it is outside the brain. The people are unconscious, but if you do a surgery timely, the patients have a remarkable improvement. This is very important. So know that this patient has epidural hematoma. It happens in young people after a road traffic accident or a minor trauma in maybe while playing. The commonest vessel is the middle meningeal artery. And if you can actually do a craniotomy and take out the clot, because there is no injury below the dura, there's no injury inside the brain, the patients make a remarkable recovery. A subdural hematoma is a hematoma which is below the dura. So one part is the dura, the other part is the you see the calyces, you see. So it is basically concave or convex. And the subdural hematoma has two varieties. One is acute, where there is bleeding in the brain. Acute subdural hematomas occurs within 3 days. Subacute happens between 3 days to 3 weeks. And if the hematoma is more than 3 weeks, it's called a chronic. But the pathophysiology of acute subdural hematoma and chronic are different. Acute subdural hematomas also happen in young people due to head injury, and the prognosis is quite bad because there's injury inside the brain parenchyma. In a chronic subdural hematoma, which happens in elderly people because the brain is shrinking and these bridging veins are bursting, it happens in elderly people. Here, the prognosis is better. And the last thing that you see here, is that I see intracellular bleed. Here, the prognosis is worst because part of the brain parenchyma has been destroyed irreversibly, and the patient doesn't make a complete recovery. You can take out the clot. Please remember, taking out the clot in neurosurgery is not the option. The most important thing is to prevent further increase in ICP and to prevent a compression of the brainstem. Is that clear?
Yes, sir.
Hello? Yes. So epidural hematoma, you should know, the short notes can come as epidural hematoma. The other is subdural hematoma, which can be acute, subacute, and chronic. Acute is a subdural hematoma, which is just 3 days old. 3 days to 3 weeks is subacute. and beyond 3 weeks is called a chronic. And the other is the intracerebral bleed, which is bleed inside the brain parenchyma. And the prognosis and the clinical manifestations and the way you manage it is different, but you should at least be able to know what is an epidural hematoma, what is subdural hematoma, and what exactly is a ICH. Okay.
So,
So as I told, epidural hematoma results from bleeding between the dura and the inner surface of the skull. It is a type of traumatic intracranial bleed, rarely occurs spontaneously. A neurological emergency bleed is venous or arterial origin, as I told earlier. The next part is epidural hematoma. Source of bleed is the temporoparietal locus, most likely the middle meningeal artery. So epidural hematoma, the commonest artery that is implicated is the middle meningeal artery. Frontal locus, anterior expandal artery. Occipital locus is the transverse or sigmoid sinuses. And what are the clinical features? LOC, lucid interval, and unconsciousness. So whenever you find a patient comes to you in the emergency with history of unconsciousness and the patient then gets better, and then again the patient gets unconscious, that is that the patient is having epidural hematoma. So why is there a LOC? Due to the initial trauma, there's a LOC. And then the patient wakes up because the blood is now bleeding in the brain and there's not enough epidural hematoma for the patient to be unconscious. And when the bleed is so much, it causes pressure effect inside the brain, the patient gets unconscious. So lucid intervals are very important. It's very important in neurosurgery that the patient had unconsciousness and the patient comes to and the patient's conscious. Never ask the patient to go away. Observe the patient. Do a CT scan. Tell him that he should be there in hospital for 1 or 2 days, because if he goes home in a lucid interval, it's likely that he might suffer unconsciousness and even die, which could be saved if he was in hospital. So, and there are certain deficits which happen according to the compression of the bed, but lucid interval is very, very, I won't say common, but it's a very ominous sign in case of an epidural hematoma. Subhematoma occurs from bleeding between the dura mater and the arachnoid layer of the meningeal covering of the brain. Source of bleed is the bridging veins, may be caused by an arterial hemorrhage. Much slower to develop into a mass large enough to produce symptoms. Acceleration, deceleration injury is common cause. Other risk factors, elderly people. In elderly people, what happens is that when the brain shrinks and the dura doesn't shrink, the bridging veins between the dura and the brain is torn because the brain is atrophic. And there's microhemorrhage in the subdural space and it slowly develops. So the pathophysiology of chronic subdural hematoma is different in the elderly. The prognosis is quite good because there's not much of brain impact. The slow collection of blood in the subdural space and people make a good recovery. But if there is a direct injury to the brain causing a subdural hematoma, which happens in young people, the prognosis is much worse. Okay. All right.
yes, sir.
Yes. So as I told, subdural hematoma, always remember 3. Acute subdural hematoma is within 72 hours, high mortality associated with major direct trauma and shearing. So this happens in young people. There's a lot of blood, it has been injured. Clinical features include headache, fluctuating LOC, loss of consciousness, confusion, dilated fixed pupil, deviated gaze, and CT scan shows an hypertense blood in the brain. Subacute is something which happens between, as I told earlier, it occurs within 4 to 21 days of the injury. Failure to regain consciousness may be an indicator. CT scan shows isodense or hypodense. Why? Because the blood is now getting liquefied. When the blood was clotted, it was hyperdense to the parenchyma. As the blood liquefies, it gets more and more iso and hypodense. Chronic subdural hematomas are more than 3 weeks, develops over weeks or months after a seemingly minor head injury. This is very important in case of elderly people, probably from repeat minor bleeds, and CT scan is hypodense. The blood is seeping very slowly inside the subdural space, and it gets liquefied, and the color of the subdural is hypodense, it's blackish compared to the color of the brain. So acute subdural hematoma, prognosis is very bad. Subacute, which is better, and the chronic. And please remember that the chronic actually starts as chronic. It is not that all subacutes and acutes become chronic. Some people start as chronic in elderly. You don't get an acute episode. It is basically a chronic subdural hematoma where the prognosis is good because Here there's no trauma as such, but only because the brain is shrinking and the dura is not shrinking. The bridging veins between the dura and the brain are being torn apart, and there's microhemorrhages in the subdural space, which causes a hematoma. Okay. So you see epidural and subdural hematoma. You see this epidural hematoma, if you see, as I told you earlier, can you see me? Can you see the picture?
Yes, sir.
Yeah, see, this is the outer part of this is the bone, and this is the dura. So whenever you see a biconvex blood in the brain, this is an epidural hematoma. Because what is important is that the dura is forming a layer here. Dura is forming a layer here. The bone has a contour, and this is biconvex. Biconvex blood in the brain is epidural. In a subdural, what's happening? This is the dura, and this is the brain parenchyma. So what happens is that it is a concavo-convex. So if you see, there's a difference between here. This is the dura, and this part is the brain sulci and gyri. So this is something like this. But in epidural hematoma, because the dura is forming on inner side, it's a smooth layer. So biconvex is epidural is outside the brain parenchyma, and subdural is inside the dura and inside the brain parenchyma. This is the subdural hematoma. So it is very important that when you see a CT scan, the pictures are similar, the same. This is a subdural hematoma because it's inside the dura, subdural, epidural outside the dura. It's called epidural hematoma. Okay. So I don't want to rush. If you see, the basic differences are, I told you earlier, symptoms are there, and whenever you have a patient with a subdural hematoma or epidural hematomas have an excellent prognosis. I repeat, they are the ones in head injury which have an excellent prognosis because there's no injury to the brain parenchyma, and if timely, if you intervene and do the surgery, then the patient recovers completely. But if you fail to do it timely, and if there is edema and further pushing of the brain and herniation, then the patient can die. So it is an emergency, but if done correctly and timely, has an excellent prognosis. Subdurals are also emergencies, but even if you do it quickly, sometimes the prognosis is not that good because the blood is inside the brain. So epidural hematomas should be given a lot of importance, and you should do the surgery immediately because the patient has a very, very good chance, nearly 100% chance of making an excellent recovery. So what is a subarachnoid hemorrhage? The subarachnoid hemorrhage is basically hemorrhages inside the brain, inside the arachnoid matter. These are conditions where there is bleeding of the aneurysms of the brain, traumatic fractures, and from amyloids and blood dyscrasias. So this is a blood inside the brain, inside the layer where the blood vessels are running in the brain. And if there is a bleeding inside the cisterns and in the blood vessel region, that's called a subarachnoid. And whenever you see a subarachnoid bleed, you should think that perhaps the patient might have a trauma or the patient might have bled an aneurysm. And what are the features whenever you think of a patient having an aneurysm of the blade? If a patient comes to you and says that I have an explosive headache, the worst headache in my life. If a person comes to you and says that I had the worst headache in my life, always think that perhaps he is having a bleeding aneurysm in the brain. I had the worst, as if someone knocked a hammer on my brain. That is a sign that you should take it very seriously. Headaches come in various colors and various hues. But if a person comes to you that last night I had the worst headache in my life, never tell that patient, take some paracetamol and go home. No, you should ask the patient to have a CT scan, probably send the patient to a neurologist or a neurosurgeon, because that might be a sign that he has bled an aneurysm. So take the history of the headache, very important. Headache history is important. Explosive or thunderclap headache, worst headache of my life. Nausea and vomiting decreased, LOC or coma, signs of meningeal irritation. So never let the headache go home. Give it importance. Whenever you take history of headache, ask how bad was headache, how did it start, was it the worst, and how do you know how do you calculate the headache? You say that between 0 to 10, where would you put your headache to? Would you put the headache to 1 or 2, or would you put the headache to 9 or 10? And most people really understand this, They say, I think, doctor, I'll put the headache at 9 or 10. It was the worst. And if you hear that, give it. As I tell you, in medical profession, as all of you are budding surgeons, and maybe you'll go further into other forms of super specialty. In India, it is not bad to make an overdiagnosis. Maybe you might be criticized, you might be told that you are doing a lot of investigations. But if you underdiagnose and if you miss it, the medical legal implications are very high. So sometimes you do it. You might do a CT scan because I've seen people who say it's a minor headache, doesn't matter, it's a headache, don't worry. No, take the history. If the headache is bad, you do a CT scan. You might be criticized that you overdo, but that's fine. It's better to overtreat than to undertreat and kill a patient. Can you hear me?
Sir.
Hello? Yes. Yes, there was a question, I think. What was the question?
Signs of meningeal irritation.
Yes, signs of meningeal irritation is very important. The most important signs of meningeal irritation is that the patient will be extremely irritable. The patient will be extremely irritable, and the patient will not be able, if you ask the patient to take his chin and try to put it on his in anterior part of the chest, he won't be able to do it. That's a very ominous sign of meningeal irritation. That if you ask the person to ask, there'll be neck rigidity. He won't be able to. And the other thing is that if you ask him to fold his leg, he will have pain in the neck because there's meningeal irritation. The meninges run from the brain all through the spinal cord into down. So whenever there's a stretching of the meninges because of the micro blood, because of the bleed. So whenever you stretch the meninges, there is pain in the meningeal nerves. So ask the patient to ask chin, he won't be able to, there will be neck rigidity. He won't be able to fold his legs properly. He will be confused. He might have a high fever. He might be irritable. And if you do a lumbar puncture, you might find increased WBC, increased RBC or infection. So meningeal irritation is important. What is important is that you take the history, ask the patient to put his chin in front of his chest. He won't be able to do it, which we can do very easily because his neck will be extremely rigid. He won't be able to fold his leg properly. If he folds it, there will be pain in the neck. He will be irritable. He will be confused. He might run a high temperature. And if you actually do a lumbar puncture, you will find blood or WBC or other infection inside the CSF. Okay. The third part that is important, intracerebral hematoma, as I told. Intracranial hemorrhage is hemorrhage that occurs within the brain tissue itself, and intraaxial hemorrhage. Two main types. Intraparenchymal hemorrhage is ICH extending into the brain parenchyma because of hypertensive vasculopathy. And intraventricular hemorrhage, ICH extending to the ventricles. So there might be blood in the brain parenchyma or in the ventricles. Both are intracellular hematoma, and causes are hypertensive vasculopathy, which is very common in the elderly, ruptured AVM, trauma, and blood disgraces. Hello, can you hear me, students? Hello?
Yes, sir.
Hello? Yes.
Yes, sir, we can hear you.
Any ICH below the age of 40, the commonest cause is an AVM, arteriovenous malformation. Any ICH between 40 to 60, the commonest cause is hypertensive bleed. And any ICH beyond 60 years old is due to amyloidosis. So if you find ICH below 40, don't think of hypertension first. Think that it could be an arteriovenous malformation, AVM, small arteriovenous malformation, small vascular tumors that are found in the brain, and that has bled. If the bleeding is between 40 to 60 ICH, the commonest cause is hypertension. And if the bleeding is beyond 60, it is due to the blood vessels become very rigid and they tend to bleed. So this is a common dictum that below 40 AVM, 40 to 60 it is an ICH, and beyond 60 it is have you heard of the term amyloidosis?
Yes, sir.
Amyloidosis? Yes, that happens in the brain and that's the common cause. So the clinical presentations are rapidly progressive severe headache, bending over several minutes, often accompanied by focal neurological deficits, nausea and vomiting, decreased level of consciousness. But see, the headache it occurs over minutes, but if it occurs over seconds, the worst headache, that is a headache of aneurysm bleed, which I told you earlier. And it can be, in fact, bleeding in the basal ganglia, cerebellum, pons, the cerebral cortex, and the clinical manifestations could be hemiparesis, it could be dysphagia, it could be ataxia, vertigo, cranial nerve deficits, coma, hemiparesis, hemisensory loss, and hemianaphylaxis. Any form of manifestations can occur. This is basically what we call a stroke. It's called a hemorrhagic stroke. A stroke is a condition where there is a limited loss of brain parenchyma leading to a manifestation in the human body. So if there is bleeding in the brain, that is called a hemorrhagic stroke. If there is infarction in the brain, that's called a infarction stroke. It's called a thrombotic stroke. So it's a form of a stroke. It's a bleeding. I see. It's a form of stroke. So coming to the complications of head injury. So neurological deficits or death can occur. Seizures. So you should, whenever you manage head injury, always give anti-epileptic medication because patients are very prone to epilepsy. Obstructive hydrocephalus. The blood in the brain obstructs the ventricles and leads to obstructive hydrocephalus. Spasticity. Spasticity is an increase in the muscle tone on relaxation. So what is a spastic muscle? Whenever the tone is increased, when you try to release a muscle, that is called spasticity. And that happens because of the upper motor neuron inhibition. When the upper motor neuron lesions are there, the inhibitory effect is gone and the tones become very spastic, very spastic. So spasticity is nothing, but when you try to do a passive movement of the arm and you find resistance, that's called spasticity. This is because the upper motor neurons, the corticospinal tract, which is normally under inhibition, it keeps everything inhibition. That inhibition is gone due to the head injury, and actually it becomes extremely spastic. The jerks get exaggerated, the biceps jerk and the triceps jerk and knee jerk, all jerks are exaggerated and the plantar goes upgoing. That's called a Babinski. Have you heard of the term Babinski sign?
Yes, sir.
Babinski. These are features of upper motor neuron lesion. The corticospinal tract keeps everything under check. When that part is destroyed, then it is basically keeps everything under check in an inhibition. When that inhibition is gone, then the jerks exaggerated, the muscles become spastic, and the Babinski goes out. Urinary complications happen because you go for what is called a neurogenic bladder. The bladder is also controlled by the brain and the spinal cord, and then you find various forms of autonomic bladder. You have obstruction, you have retention, you have incontinence, and the overflow incontinence. So the bladder can't empty because the bladder is coordinated with the brain and the spinal cord. And if that can't happen, the bladder becomes autonomic, and the bladder then cannot function properly. So what happens is that there is usual retention, there's obstruction to the flow, and there is sometimes what is called incontinence. Aspiration pneumonia is common in patients with head injuries because the patients can't breathe properly, patients can't swallow properly, and what happens is that you can't cough properly. So you can't cough, even if you put the finest speck of water in your throat, you cough out. But here the patient can't cough, and so micro amount of fluids starts accumulating inside the lungs, and you got pneumonia. Cushing's ulcer, ulcers named after Dr. Cushing, are special ulcers in the stomach, which happens due to raised ICP, and you have ulcers in the stomach. Whenever there's a raised ICP and there's ulcers happening, that's called Cushing's ulcer. This is very important. It has been seen that patients with under stress, under raised ICP, have ulcers forming inside the alimentary tract, especially in the stomach and intestine, is called Cushing's ulcer. Neuropathic pain. Pain which is neuropathic is different from pain which is nociceptive. Nociceptive pain is pain where there is an irritation to your surface. And neuropathic pain is when the nerve itself is damaged. When you irritate the nerve endings, you get what is called a nociceptive pain. The nerve is fine. That is called a nociceptive pain. And neuropathic pain is pain where there is damage to the brain. Classical example is diabetes, where the nerve is damaged. So you can't just deal these patients. Okay. Then there is deep venous. Have you heard of the deep venous thrombosis? DVT. Very, very important. The patients are paralyzed. The patient cannot move his legs. So what happens is that there's clot forming inside the venous system, the deep venous system of our legs, and that clot can go into the lungs and cause a fatal pulmonary embolism. So in head injury, what is important is that you should start what is called mechanical prophylaxis from day one. You start moving the legs, you do a physiotherapy, you put on dead stockings, it's called thromboembolic deterrent stockings, and you also put a pneumatic compression so that the squeezing action of the muscles in the legs, the cuff muscles are there, blood is not allowed to accumulate to form a clot, and so dislodge and go to the lungs, which is very, very fatal. So pulmonary embolism is a definite sign of concern in head injury patients with patients whose legs are paralyzed and they can't move. And we can't go for chemoprophylaxis. We can't go for low molecular weight, heparin, all these things in case of head injuries because that will lead to further bleeding inside the brain. So mechanical prophylaxis in the form of stockings, in early movement, trying to mobilize, trying to keep the legs moving is very important. Or you lose the patient, pulmonary embolism, and cerebral herniation. I'll tell you a bit of cerebral herniation. What is herniation? Brain herniation is a deadly side effect of very high intracranial pressure. That occurs when a part of the brain is squeezed across structures within the skull. Brain herniation represents mechanical displacement of normal brain relative to another anatomic region, secondary to mass effect from traumatic neoplastic ischemic infection. So if you see, these are the very fundamental example of what cerebral herniation. If you see the herniation, which is the one that is called uncal herniation. So number one is uncal herniation, where this part is called the uncus of the temporal lobe, and that herniates between the brainstem. I'll tell you, this is the brainstem, this is the brainstem, and this is a part of temporal lobe. This is called uncal herniation. Okay, so it's a very uncal herniation. Okay, central tentorial herniation is the one that is coming down straight. The whole of the supratentorial is going down and is pushing down. This is called tentorial herniation. 3, cingulate. Singular herniation is when one part of the brain hemisphere herniates under the interhemisphere fissure and goes to the other side. This is called a cingulate. That's number 3. And sometimes what we call upward herniation, where the pressure in the posterior fossa is so high and the pressure in the supratentorial is low. There's a herniation of the brainstem going upwards. It's called upward herniation. And the last is the tonsillar herniation. Tonsillar herniation, sorry, wait. Where there is the whole cerebral tonsils, number 6, cerebral tonsils herniates inside the spinal cord. The other one herniation that is found when we do a flap here, when you do a cranial flap here, and from that bone flap, part of the brain herniates inside the skin. That is called a flap herniation. So that's not important, but you should remember that these herniations are important. One is a herniation of the uncus, which is part of the temporal lobe, which herniates between the brainstem, which cause specific signs. The other is the central herniation, where the whole of the brain, upper brain, herniates through the brainstem into tentorial incisura. And the other is obviously the singular herniation, where part of the brain on the left side herniates under on the right. This is a single herniation. As I told, this is a calvareal herniation, is the one where there is an operation, transcalvareal herniation, and upward herniation and tonsillar herniation. So these are, I don't think so. You should just know the names of what single herniation. It's the most common type of innermost part of the frontal lobe is scraped under part of the vas cerebri. The dura will matter at the top and it goes down. Here, obviously, if you have any idea of how the brain structures there, the patient will have a weakness of the legs only, because the part that is herniated is the one that controls the leg movements. So it's not important. You just remember that single herniation is herniation of one hemisphere of the brain to the other side. And uncal herniation is the one that is very deadly. Common subtype of cerebral herniation following raised ICP. Innermost part of the temporal lobe, the uncus can be squeezed so much that it moves towards the tentorium and puts pressure on the brainstem, most notably on the midbrain. And the manifestations are ipsilateral fixed dilated pupil, compression of the homonymous hemianopia, compression, and the hemiparesis of the other side. So I think I'll take another class where you should know that if there is a dilated pupil on one side and weakness on the other, and the patient is unconscious, you might think of uncal herniation. So diagnostic studies, as I told, is a CT scan, GCS score less than 15 after blunt head trauma, warrants a patient with no intoxicating concentration of an urgent CT scan. CT findings, as I told, let's recall, this is the epidural hematoma. You can see it is biconvex, as I told earlier. It's a classical example of epidural hematoma. And this is subdural hematoma. See, this part is convex and this part is concave or convex. This is important. So for DNB students, this is important that you just can differentiate between a subdural epidural. Biconvex epidural, very good prognosis if you do a timely surgery. Subdural hematoma, this is an acute subdural hematoma because you see the blood is hyperdense compared to the brain parenchyma. It's an acute subdural hematoma. And there's some blood in the interhemisphere fissure also. Here, obviously, the prognosis is not that good because the brain is also affected. This is a classical example of subarachnoid. See, these are basically places where the brain blood vessels run, and whenever there's bleed, so you see how patchy it is, how patchy. These are what is called basically basal cisterns. This is the interhemispheric cistern. This is the sylvial cistern. This is the brainstem. These are called the ambient cisterns. These are cisterns where the blood vessels run, and if there's bleeding there, it's called basically what is called subarachnoid hemorrhage. And this is ventricular bleed. Blood has burst inside the ventricle. So these 4 types of bleeds are very important. Let me go back to the previous slide if you just to make it clear. Just to make it clear. So epidural hematoma, subdural hematoma, subarachnoid bleed. Just remember the pictures. Epidural is this, subdural is this, and subarachnoid and interventricular. So you get a good idea that whenever you say CT scan, you see this blood, because people tend to make a mistake of what is a subarachnoid hemorrhage. This is subarachnoid. So there's blood actually filtering through the blood vessel, the passage of the vessels. Here the vessels are running, and so you see it's not blood all over. It's as if it's following a tract, and this tract exactly is the features of a subarachnoid hemorrhage. Diagnostic studies are MRI superior for demonstrating the size of an acute subdural hematoma, but I will tilt the cerebral angiogram if hemorrhage is confirmed. Cervical spine X-ray, as I told earlier, EEG and lumbar puncture. Management, do you want to go to management today or you want to go to management later? Hello? Hello?
Sir, please continue.
Later.
Will I continue?
Yes, sir, please continue.
Yeah. Okay. So remember that what is important in the management of head injury is, as I told, that first and foremost, you see what is the Glasgow coma scale. It's very important. And you put the patient in the category of whether the patient has a severe head injury, where the coma scale is below 8, whether the coma scale between 9 to 13 is moderate head injury, and above 14 to 15 is a minor head injury. Always remember that a patient who has head injury which is severe, 8 or below, warrants an endotracheal intubation immediately. Immediately. It is not because of any other thing, but if a patient is unconscious to the level that he is GCS 8 or below, and if you don't actually protect his airway, then the further hypoxia that can happen can cause irreversible damage to the brain. So a patient who is GCS 8 needs intubation. He should be intubated and put on a ventilator. There's no dictum or there's nothing against it. It is a protocol followed all over the world. So people will ask you that why should I intubate a patient who is breathing perfectly? You're not intubating because of the patient is breathing properly. You're intubating to prevent further brain damage due to hypoxia. You're preventing further brain damage due to hypoxia. You're preventing further damage to the lungs for aspiration pneumonia. That's why intubating. You're protecting the airway, and you need a proper ventilation. You must put the patient maybe on a volume control for proper oxygenation to the brain. Because if a patient is breathing well, but the oxygen not going to the brain, he has further hypoxia, further irreversible brain damage, and where the patient could have been saved, he dies. Cautiously lower blood pressure. This less than 130, that is the mean arterial pressure, but avoid excessive hypotension. It's very important that you cautiously lower the blood pressure, because if you do a very high degree of hypertension, what happens is then that the cerebral circulation, if it falls below a certain level, oxygenation to the brain will fall. So you just can't lower the blood pressure according to your will. You should keep a mean arterial pressure as 130. Okay. Rapidly stabilize vital signs and simultaneously acquire emergent CT scan. Maintain U volume using normotic rather than hypotonic fluids, and avoid hypothermia. Don't let the patient overheat, and facilitate transfer to the operating room or ICU. And by this time, you should know whether the patient needs to be managed conservatively or the patient needs to be surgery. And then according to that, you take the patient to the operating room or ICU. Management, decrease cerebral edema. How do you do it? What are the various measures of decreasing cerebral edema? Modest passive hyperventilation to reduce PSO2. CO2, you know, if there is hyperventilation, if there is CO2 washout, there is vasoconstriction in the brain. Whenever there is a rise of CO2 in the blood, there is vasodilatation. So if there is moderate amount of constriction, it lowers the brain pressure. Because the brain pressure is a pressure combined of the brain parenchyma, the CSF, and the blood. So if there is a large hematoma in the brain, so the pressure will increase. So if there is hematoma, the only way you can lower the pressure is you can lower by actually maybe lowering the amount of blood that is going. You do a hyperventilate, the CO2 washes out, and there is a vasoconstriction. The other important medication we give very often is mannitol, which is given at the dose of 0.5 to 1 grams per kg. It's basically is a carbohydrate. So mannitol, the most important function of mannitol is that it actually causes osmotic gradient between the blood vessels and the brain parenchyma. So because of the gradient being higher in the blood vessels, it draws in fluid from the brain because of the osmotic gradient, and it tries to draw in more fluid from the brain. But that is not its only function. The other functions is that because it lowers the viscosity of blood, because it draws in more fluid, the blood actually can go to the nooks and corners of the brain, and there's better oxygenation. And the third important is it has some antioxidant effect. So mannitol lowers brain edema by drawing in fluid from the edematous brain inside the blood vessels. By drawing in more fluid, actually it lowers the blood viscosity, so the blood can flow to the nooks and corners of the brain, and there's better oxygenation, so that part of the brain doesn't die. And it has some antioxidant effect. It protects the brain. It's called a brain protectant. We also give Lasix, but that's not given. Elevate head 20 to 30 degrees. So whenever you elevate the head, there is a better venous drainage. So venous drainage, and the brain edema tries to fall. Sedate and paralyze if it's necessary, because if you sedate the patient, the chances of any epilepsy happening, any convulsion happening is low. Any features of convulsion can actually potentially raise the ICP suddenly. If there's a convulsion in the brain, it can raise the ICP to a certain extent that it can cause an herniation. So hyperventilate, mannitol, elevate the head, and sedate. And the most important, obviously, if there's a large trauma, large bleed, you have to go for the operation. These are ways to manage. As I told earlier, the whole gamut of neurosurgery head trauma is to prevent increase in pressure. It's not that you take out the blood completely. You have to decrease the pressure, prevent the vital structure, that the brainstem, from herniating. You should prevent the vital structure from being compressed, and you should get the pressure down to whatever pressure, like 15, 20 milliliters of mercury. You should put it down. You can't allow the brain pressure to go up, because there's no way the brain pressure can go out. There's a rigid skull outside. So the brain pressure will go inside. It will compress each other. It will compress the brainstem, and the patient will kill you. It will kill you. It's not like bleeding in the stomach, because where the stomach can distend. Here, the bleeding inside the brain will only create further increase in pressure inside. And outside, there's no way the patient can go, because there's a rigid skull outside. So that's why it is so important that you understand how quickly you should lower the ICP, either through medication, either through changes in body posture, raising the head, or if you need in fact, you need all of three. You need medication, you need surgery if surgery is warranted, and you need the posture changes to prevent ICP. So these are the various methods to prevent raise in ICP. And once the ICP is controlled, you can well be certain that the patient might be saved. If you can't control the ICP, if there's a herniation, if there's secondary brain damage, then you lose the patient. That is the most important thing in a head injury patient, that you have to control the ICP, because the head is inside a rigid skull, and the pressure has no other place to go but to go and cause further pressure inside the brain itself. Is that clear?
Yes, sir.
There's a question: when is mannitol given in head injury? In head injury, we give mannitol, especially in there is diffuse injuries. We give mannitol. We give mannitol when there is also in subdurals and epidurals. Whenever we think there's a raised ICP, we believe we can give mannitol. But the problem with mannitol is that you can't give mannitol for very long. As I told, mannitol actually is a sugar which causes raised osmotic pressure inside the blood and draws in fluid from the brain. But after 2 or 3 days, what happens? This mannitol starts going inside the brain. So it causes a reverse osmosis. Now the fluid which was supposed to come from the brain inside to the blood to be let out in urination, the mannitol seeps inside the brain and draws in fluid from the blood itself in the system. So never give mannitol for more than 2 or 3 days, because mannitol then starts going inside the brain. Give it early, give it maybe in short boluses of 2 or 3 doses for 2 or 3 days, and then stop and see the monitor. But giving mannitol for longer than 3 or 4 days causes more harm than good. And you should be also be careful in giving mannitol with people with hypertension, because with a high degree of blood fluid in the blood, it causes hypertension. It causes cardiac anomalies if the patient has cardiac issues, and people have acute renal failure. It causes direct damage to the renal tubules. So one should be very careful when to give mannitol. But overall, mannitol is a fantastic medication to give a temporary relief to reduce ICP. But as I told, it is just not mannitol. It is hyperventilation, it is intubation, it is posture change, it is hypothermia, and everything actually are used to reduce ICP. And when nothing can be done, we go for what is called a decompressive craniectomy. We take out flaps from 2 sides. We take out the skull bone from 2 sides. So let the brain parenchyma to actually move out, and then rather than compressing inside. The whole idea of controlling ICP is to prevent damage to the brainstem. Once the brainstem is damaged, once the initial all the 5 or 6 reflexes starts getting affected, then you lose the patient. You can have a lot of damage to the brain, but you should prevent the brainstem pumping damage, and that will invariably happen if you don't lower the pressure, because ultimately, because it being the most central part of the brain and there's a lot of pressure all around, if it can't go outside or if it can't be controlled, it will actually control and compress the brainstem. If there's a brainstem compression, then there's what is called a brain death, and then you cannot save the patient. And surgical, I think no surgical intervention if collection is less than 10. It's discretion of the surgeon when you do surgery. But obviously, please remember that if there is a collection of more than 30 ml of blood, if there is a midline shift, if the brain shifts from one side to the other for more than 5 millimeters, in a CT scan we can see the shift of the brain from the it's measured from the direction of the septum pellucidum, and if the shifting is more than 5 millimeters, and if the blood is more than 30 ml, then we suggest that this patient needs some form of surgery. All right. And the GCS score decreases by 2. So these are the various indications where we do surgery. In subdural hematoma with GCS 15 hematoma more than 10 or more than 5 millimeters midline shift requires surgical decompression. And SH when a cerebral aneurysm is identified or angiography declipping and coiling is done to prevent bleed. Management, surgical. So basically the types of surgeries we do in head injuries are bar holes, where we do 2 bar holes, one on the frontal and one on the parietal. When we know the underlying blood is fluid, like a subdural hematoma is totally fluid, and then we just suck out the blood, the fluid blood, and then close. A craniotomy is a bone flap which is temporarily removed from the skull to access the brain. And a craniectomy is similar to a craniotomy, but when you don't put the bone flap back. Maybe there's a massive injury to the brain and you have to take out the part of the skull. But if you want to push the bone flap back again, it will increase the pressure. In those times, what we do a decompressive craniectomy. We take out the bone flap. We take out the bone flap and throw it away, or we keep it inside our abdomen, in the tissues of the abdomen, or we keep it in the fridge. And later when the brain relaxes, maybe after 2 or 3 weeks, we put it back. That's called a cranioplasty. So bar holes are small holes where we take out fluid, liquid blood. A craniotomy is where you take out a bone flap, do the surgery, and you find the brain relaxed, you put the bone flap back. A craniectomy is when you take a craniotomy, but you can't put the bone flap back because the brain is still very edematous, very, very tense. Then you put it. And the last is that when you, and the last thing is the cranioplasty. When you take the bone flap, keep it inside the human body, maybe in abdominal subcutaneous pouch, or in the in your OT, and then you put it back after 2 or 3 weeks, or maybe in a couple of months. That's called a cranioplasty. Cranioplasty is any procedure where you put a bone flap or an artificial, maybe a titanium mesh or a cage to cover the bony gap in the skull. All right, is that correct? Is that clear?
What's the
Yes,
difference
sir.
between craniectomy and cranioplasty, sir? Plasty, we will keep it back. Craniectomy, we won't keep it back, sir.
No, craniectomy is when you don't put the bone flap back in immediately after the operation. Okay. And cranioplasty is something when you put that bone back after a time interval. So what can happen? You can do a craniotomy. You take the bone flap and you put it back. That's called a craniotomy. You take the bone flap out and you don't replace it. That's called a craniectomy. When you take this bone after 3 weeks and put it back again in the skull when the brain is relaxed, that's called a cranioplasty. All right. So a cranioplasty is nothing but an extension of craniectomy where the bone flap was not replaced, but after 2 or 3 weeks, either your autologous bone, the bone that was of the patient concerned, or some artificial material in the form of titanium is replaced to cover the gap of the skull when the patient's brain has decreased in edema and pressure. That is called a cranioplasty. It is never done in the same sitting. So you can do a bar hole, you can do a craniotomy, you can do a craniectomy, but cranioplasty is always done maybe 2, 3, 4 weeks later when the brain relaxes. Is that clear?
Yes, sir.
Sir, indications of
Yes.
indications of
Yes, ask me please.
indications of Warhol, sir, Warhol surgery.
Indications of Barlow is that when the blood in the brain, when the subdural blood, as I told you, is absolutely liquid. If you do, if you see the CT scan and find that it is a hypodense, you understand the blood is no longer clotted. It is not like a jelly. It is not like a thick curd. It is totally liquefied. It is basically a liquid, very liquid blood. The blood, basically what we call just like serum, where all the protein has actually gone and only serum part is there, is hypodense. You just put 2 bar holes and the blood can be just come out. You can just suck out that. It's because it is fluid. But if the blood is clotted, if the blood cannot come out from a single hole, then what you do is you take out a huge flap, you take out the curdish blood, which is still clotted, where the blood is subacute or it is acute, and that is called a craniectomy. But when in a subdural hematoma, the blood is fluid, the blood is just like water, it is totally liquefied, just a single hole and the blood rushes out. It's a simpler surgery, it's a smaller surgery, and it can be done very effectively. So that is the indication of bar holes. And the other thing is bar hole is that when you do a craniotomy also, you have to do bar holes to connect the points to do a craniotomy. So that is also indication. You can do a bar hole, just take out the blood, or you have to do 3 or 4 bar holes in the brain and then you connect the 4 bar holes and take out the flap. That is also indication. So bar holes are the fundamental surgery in the brain. You do a hole in the skull, and or you do several holes in the skull, then you join the holes by a cutter and then take out the flap. That is called a craniectomy or a craniotomy. Okay.
Sir,
And
yes. While doing all these surgeries, we are only dealing with decompression of brain. Do we need to control the hemorrhage also?
Of course, that is the most important. The whole dictum of brain surgery is that the hemorrhage is the brain is very edematous. The brain is very edematous, and the blood vessels are bleeding all over. So on one hand, you should control the brain pressure. On the other hand, you have to control the brain bleeding. The only thing that is important in brain is controlling pressure and preventing further bleeding. And unlike in other part of the body, you can't press on anything. If there is a long bone fracture, you can actually press the tissue on the bone, or even in the abdominal injuries, you can actually squeeze that part. But in the brain, you can't squeeze the brain onto anything because that will cause further damage. So we use a very special type of cautery called a bipolar cautery, where we try to hold like twitches the 2 vessels and we burn it. So bleeding is the most important catastrophe in the brain surgery is bleeding, which is very difficult to control at times, and to reduce the pressure. So on one hand, there is increased pressure, the brain is edematous, and the blood vessels starts bursting everywhere. There are procedures, there are mechanisms by which we control. Then we take some time. When we find that the bleeding has stopped and the edema is not getting any back, then we close. If there's brain has swollen too much, then we throw the bone flap out. But if the brain is not swollen, then we put the bone flap. So we do a craniotomy or craniectomy. Okay. So, and the other management, obviously, the ones you know is that we should always give antihypertensives if there is bleeding, and anticonvulsants, reduce frequency of seizures. So always give some form of antiepileptic. The ones we commonly use are the ones which is called the phenytoin group of medications, or we use other antihypertensives, and you should give antipyretics to prevent fever, and you can give vitamin K and FFP if there is chances of bleeding. So these are things that you should be very careful after the surgery, that is the patient getting adequate antihypertensive so that the patient doesn't go into some form of repeat hemorrhage or encephalopathy, and mannitol to reduce the pressure in the operated brain, anticonvulsants to prevent seizures, because the blood in the brain from the contains iron, and the iron is very, very epileptogenic, very epileptogenic. Whenever there's a bleeding in the brain, it causes seizures. Why? Because the iron inside the blood in the hemoglobin is very epileptogenic. It causes seizures. So you should give some anti-epileptic measures like phenytoin, or nowadays we use the word levetiracetam, Levipil, or valproic acid, or carbamazepine. But the common ones we use are Delantin, that is phenytoin. If you think there is a degree of bleeding, you should give vitamin K, or the fresh frozen plasma, or warfarin we should be given. And antacids, as I told, prophylaxis for Cushing's gastric ulcer, and glucocorticoids may help reduce. But one thing, please remember that steroids have no role in head injury. Steroids have absolutely no role in head injury. Steroids have good role in brain tumors. Steroids have good role in brain tumors, but as far as head injury is concerned, all randomized controlled trials have proved beyond doubt that steroids have no role. Rather, they have deleterious effect. If you give a lot of steroids, it causes immunosuppression, it causes a lot of infection, it causes a lot of ulcers, it causes a lot of bleeding. So never give steroids as an indication to prevent further deterioration. You can give steroids if the patient needs it, obviously, but you can't. Steroids have no role in head injury. That's a single one-liner. It has no role in the management of head injury, but it has role in the management of brain tumors. It has a role in the management of spinal tumors. For head injury, steroids have no role. That's as simple as that. It has no role. If anyone tells you, you just tell categorically that all studies have proven that steroids have no role. So there's no use giving steroids. And preventive measures, obviously, you know better than me. To prevent car and motorcycle accidents, to wear safety helmets, obviously. That's a more social issue. That's more an issue of actually people being conscious about it. But it's not in our hands, really. But obviously, prevention is better than cure. And rehabilitation, ambulatory and home care is important, because these head injury patients, they need a lot of rehabilitation. Their functions sometimes don't come back, maybe even after 6 months. Many of them have hemiparesis or paralysis. Many of them have cognitive functions. So you need a lot of support. You can't keep these patients for absolutely time immemorial in the hospital. You have to send them home. So you should see whenever the patient going home, is he having a proper nutrition, bowel and bladder management, because these are the source of infection. Spasticity, as I told, as it affects the brain, the muscles get very spastic. So if you cannot control the spasticity, that will be permanent. Even if the person ultimately starts to move, he can't move because the legs are spastic, the arms are spastic. So you should go for the physiotherapy, prevent spasticity. By medications, we give antispastic medications, but the most important is proper physiotherapy to keep the limbs in movement, because there's a tendency for the limbs to become spastic, and they are permanent. And maybe the patient is totally conscious, maybe after 6 or 7 months, but he can't move because his legs are spastic. It happens very often. Dysphagia, difficulty in eating. So this is very important. You should be very careful that the amount of food you're giving, whether it's actually, and at times you can actually go and feed the patient for a long time on rice tube, or you can go for a peg and then start feeding the patient later. Seizure disorders are common, and obviously family participation and education to give support to head injury patients, because most patients head injury are young patients. They're in the prime of life, and they don't know what has happened. The family is unsure what has happened. But as I told you, a great surgery, a great work in the hospital is zero if you don't see to the minor, small things like prevention of bed sore, prevention of deep vein thrombosis, prevention of chest infection, proper nutrition, prevention of spasticity. These things are very important. This is the holistic approach to head injury, because it is just not enough to do a proper surgery, because proper surgeries do only part of the work. They may be life-saving, but if you want to keep that patient back into society at some juncture, these small things are extremely important. These things do not need any heroism. They do not need a lot of skill. You just should be aware that whether the legs are getting swollen, whether the beds are developing, whether the chest is getting infected, whether the patient is getting problems. These are small things you should check every day. And these things can be seen very easily. And that makes all the difference between you saving the patient and you not saving the patient. You don't see the small things and the patient dies. Okay, so I think this is what I tried to explain to you. Any questions? I think it was quite a big topic. I just wanted to give you in a nutshell about head injuries and how
The
to
role of
approach it.
Aptoin in medical treatment, sir, in this hemorrhage.
Role of?
Aptoin. Can you answer? Aptoin.
Yeah, role of Eptoin is that basically I told you that whenever there's a bleeding inside the brain or there is trauma inside the brain, you know, the brain has various areas which is called eloquent areas of the brain, like the frontal cortex. There's the part of the brain in front of the in central sulcus, which is the motor cortex. Is the motor cortex. So if there is bleeding in the motor cortex, if there is irritation motor cortex, it leads to epileptic seizures. It leads to seizures. Like so, when you give Eptoin, we actually help in preventing a seizure. If there's a seizure in the brain, in already a hypoxic brain, if there's further seizure, it causes in further edema, and it can deteriorate the patient. In a patient who is already comatose, if there is a convulsion, it causes further edema in the brain, and the patient can become. So we should give in some form of anti-epileptic measures to prevent prevent an epilepsy. Right, prevent epilepsy.
Sir, what is the dose and how many days should we give Aptoin, sir?
The dose is actually, we normally give about, for a 70 kg person, we give about 300 milligrams. That is about around about 5 milligram per kg body weight. So initially, if there is what is called, if there is a status epilepticus, you should go for about, you can go up to a 1000 milligram dose in over 15-20 minutes, and then you should give a standing dose about 5 million per kg body weight for the next 24 hours or 48 hours. This is the dose where you give for a status epilepticus. But normally, even if there is no status, you should start the dose at about 5 milligram per kg body weight. That comes to about 100 milligrams per oral dose. So about 300 milligrams of Eptoin per day is sufficient to prevent epileptic fits in a normal adult. Okay, normal adult.
Sir, is any specific criteria to take CT, sir? How pediatric patients CT criteria anything?
CT.
Yes, sir.
There's a lot of any patient who has a head injury with a loss of consciousness, any patient who has head injury with a skull bone fracture, or any patient who has head injury where the coma scale is just even 1 below 15, CT scan is advocated. So if there is a history of a patient comes to you with a coma scale of 15, but he had a history of LOC, you go for a CT. If you think that in the skull bone there's a fracture, if the patient is completely fine, you go for a CT. If you find he is slightly confused but nearly okay, then also you go for a CT. Only when a patient comes with no loss of consciousness, no fracture, and the coma scale is 15, you may avoid the CT. But even if that case, if you do a CT, that's fine. Hello?
This criteria is same for pediatric. Hello?
In pediatric, we don't do a CT that quickly because a CT is a radiation which can harm the brain, which can harm the brain. In a pediatric, we sometimes go in what is called for ultrasonography, USG, and sometimes we go for MRI. In a pediatric, we don't go to a CT that often because a CT scan has a very high radiation dose. But yeah, the criteria is more or less the same. If the child has a coma scale below 15, is a fracture, if the child has a loss of consciousness, you should go for a CT. You should go for a CT, but you should be very careful in a CT in a child because of the high radiation on a developing brain.
Sir, fixed gauge and fixed gauge is suggestive of the third nerve palsy and also the dilated fixed pupil.
No, dilated fixed pupil, you see the pupil constricts because of the two things. No, there's the oculomotor nerve, oculomotor nerve. Oculomotor nerve is the one actually that it constricts the pupil. So if there's a third nerve palsy, if the ocular nerve is not working, then there is no way the pupil can constrict. So the pupil remains dilated. So that is basically a feature of third nerve palsy. So whenever put light on the eyes, the pupils constrict because that is the way the third nerve constricts the pupil. But if the third nerve is not...
Why deviated gaze?
Deviated gaze happens on two things. That's because of the ocular cephalic. If there is a tumor on part of the brain, if there's a tumor on this part of the brain, on the right side, the gaze is found to be deviated to the left. And if there is a seizure on that side of the brain, if there's a seizure on the right side, if there's epileptic fit on the right side, is the point the gaze is deviated to the side of the fit. If there is a trauma or a tumor on the right side, the gaze will deviate on the left. So that's the way the ocular cephalic reflexes work. And if there is a seizure, there's no trauma, there's no injury to the brain, but there's a epileptic fit, the brain gaze will deviate towards the side of the fit. And in the other case, it will fit in case of trauma or an ICH will fit to the other side. That's the way it happens.
Sir, in GCS score, can you please explain about that verbal response, that difference between the incomprehensible, inappropriate, and confused words, sir?
Yes. So it's very important. So V1, 2, 3, 4, 5. Okay, so this 5. So when a person is in V5, the person is, I'll give an example. What is your name? He tells your name. He is telling the right answers and he is oriented to time and space. He knows where he is, what time of day it is, so it is not only speaking the correct words, but it's oriented to time and space. That is V5. In V4, the patient knows his name, the patient knows his son's name, the patient is not oriented to time and space. He doesn't know that this is the daytime or this is the nighttime, and he doesn't know whether he is in hospital or in the room. That is the only difference between V4 and V5. In V3, he says a few words like, I'm getting hurt. He's saying a few words. Words are coming out. Words are coming out. Words are coming out. That is V3. In V2, no words are coming out. It sounds like he's making oof, ah, that is V2. And V1, there is no response. So V1, no response. V2, sounds, only sounds, no specific words. V3, specific few words. V4 is speaking quite well, but not oriented to space and time. And V5 is speaking perfectly like you and me. He knows what is his name. He knows what is his father's name. He knows this is night. He knows he is in Calcutta. He knows this, he had an accident. So he's totally oriented to space and time. That is the verbal response to the Glasgow Coma scale. All right.
Sir, if GCS less than 6, is it contraindication of the barbell? As some centers usually practice.
No. If the GCS is 3, sometimes we don't go for operation. But if the GCS is less than 6, see, that is a discretion of the surgeon or the doctor. If the GCS is less than 6, if the pupils are dilated, then actually there are a lot of criteria to do an operation or not. But a GCS less than 6 is not a contraindication to barbell operation. But a GCS which is 3, where the pupils are dilated and the coma scale is 3, normally in centers all over the world, we don't operate with the GCS because it has been seen that the prognosis is absolutely, it is equally bad. But GCS 6, no, not in our centers. In GCS 6, you can make an attempt, but you have to tell the patient relatives that the prognosis is very bad, that we are making an attempt. That's it. That's important.
Sir, is coma and that vegetative state is same, sir?
No. Basically, we don't use the word coma. It's basically a vegetative state is a person where the cerebral cortex are not functioning properly. That is a form of coma where the cognitive functions are lost, but the brainstem functions are intact. So his pupils are reacting, his ocular cephalic, he is breathing, he is swallowing. So that is a state of vegetative state. In a coma, the patient is basically unconscious, where maybe his cortex is functioning or not functioning, the eyes are closed, he is not responding in any way, he is in a coma actually. But in a vegetative state, it is very broad actually, but the patient is actually looking at you. He is not having what is called a purposeful look, but he is hearing and he is actually staring. That is a vegetative state. In a coma, the patient is unconscious. The reticular attenuating system, the part of the brainstem which controls of consciousness, awake, that part is affected. The patient is actually sleeping. Depending on the depth of the coma, you can say whether he is in GCS 13, 14 or he is in GCS 3. So that is coma, where the RAS, reticular attenuating system, is affected and the patient is in some form of deep sleep. In a vegetative state, the patient is not sleeping, but the patient is not aware also because his no functions are working, but he is alive, he is breathing, he is He's swallowing. He's actually looking at you. His pupils are reacting. That's a vegetative state.
Sir, can we get a GCS of E1 M5 like that, or E2 M5 in brain injury?
Actually, the GCS doesn't work that way. When E1 and M5 and V5 doesn't work because it is functions like, it's very rare to find GCS of E1 and V5 and M6. It doesn't happen that way. When the whole, you know what I mean? So when the brain functions
Yes,
going
sir.
down, everything goes down. Yes, but there are certain conditions where the GCS can't be seen. Like if a patient has a tracheostomy, you can't see the verbal response. So what we do is that we put E4, VT, M5. So VT means verbal is tracheostomy is done. Or
Sir.
if there is a lot, or if there's a lot of edema in the eyes and the patient can't open his eyes, so you can't do a proper GCS there. So there are certain indications where GCS can't, but a patient with a E1 and V5 and M6, it doesn't happen. Very good question, because the cognitive function of the brain doesn't affect only the verbal or the motor. It also affects the eyes. So if the GCS is good, all the parameters are nearly good. If the GCS is bad, all the parameters are bad. But we do have patients which is E2, V2, M5. The motor is the most important. We do have patients where patient has E2, V2, M5. We have, but E1, V1, and then M6, it doesn't happen that way. It doesn't happen.
Sir, if the patient has like raccoon eyes and he can't open his eyes, then how do you score the E score?
We don't put the score. We don't put the score. There we put E is not put the. We only put the score according to the verbal response and the motor.
Any other score apart from the GCS used in the neurosurgery? Any other score?
No, we don't. We know all the other scores have been put into trash. We don't put any other score. There are a lot of scores earlier, but none of the scores are given importance. The only score that is important all worldwide is the Glasgow Coma because of the simplicity and because of its authenticity. It's very simple and very authentic, and the Glasgow Coma scale doesn't see the brainstem reflex. It just sees the level of consciousness. There were a lot of other scores, very complicated scores were done, but it is no longer used nowadays.
Sir, about
Sir,
the
in paralytic patients, how to check for motor response? Sir, you told to open the tongue, to show the tongue. But M4, M5, there is decerebricity, decorticate. All these things, how can we tell, sir?
No, actually, decortical rigidity and decel rigidity are the terms which were earlier used for motor response. Like, I'll tell you motor response is that you ask the patient to show his tongue, obeying a command. If he obeys a command, that is M6. Any command he obeys. Maybe he might be paralyzed from his legs. He can't open it. It is not a function of the motor function. It is a consciousness of his motor. M5 is localizing. You give a hard pinch on his chest and his hand comes towards the hand, try to remove it. That's M5. He is localizing to the point of irritation. M4 is that you pinch the person and is trying to go away from you. That is called withdrawal. M3 is basically what is called decorticate. He is trying to abnormal flexion. That's called the D. And M2 is abnormal extension. So decortication and decerebration are actually M3 and M2. But nowadays M3 means abnormal flexion and M2 means abnormal extension. So decerebrate is when the patient is abnormally extending. That's decerebrate. But that is actually M2. And M3 is decortication, where the brainstem is still functioning and the patient is trying to flex. That is called M3. So M6, M5, M4, M3, M2, M1. Forget the other things. Decortication, decerebrations were terms used before the age of the Glasgow Coma scale. Nowadays we use only the terms of basically obeying commands, localizing, withdrawing, abnormal flexion, abnormal extension, and no movement. All right.
Sir, where do we measure the CSF glucose in brain trauma?
Hello?
Hello, sir. Where do we measure? How do we measure and when to measure the CSF glucose?
You measure the CSF glucose in. We don't measure the CSF glucose in head trauma. Actually, we only measure the beta transferrin. But CSF glucose is measured when we think there's some form of meningitis.
Okay.
In case of viral meningitis, in case of bacterial meningitis. In viral meningitis, the glucose doesn't go down much. But in bacterial meningitis, the glucose goes down, the protein goes up, and that is measured in the pathology. We take the CSF and there's ways to measure the glucose. So in viral meningitis, just remember the protein doesn't change much, the glucose doesn't change much. That's a viral meningitis. In a condition called Guillain-Barré syndrome, the protein goes up very high. In bacterial meningitis, the protein goes up and the glucose goes down. And that by seeing the various parameters of glucose and protein and cells, we can from the CSF we can understand what condition. But in head injury, glucose is not measured. We only measure the beta to transferrin to know whether the CSF is coming out or not. Okay, CSF is coming out or not.
Sir, in pre-operative, pre-hospital care, you said never do suction oral. Is it for all the cases of head injury, or where we suspect CSF leak, there we avoid oral suctioning?
Yeah, good question. Where we suspect CSF leak, don't do oral suction. But even if you don't suspect, if you have any doubt, then don't do oral suction. But even if you have a doubt, then don't do oral suction, because when you're putting that oral suction through your mouth, it's quite chance that instead of going inside your pharynx, inside the trachea, it can take a path inside the brain. There might be a fracture at the base of the skull. So if you have any doubt, ask the anesthetist to come and ask him to see a laryngoscope and see it properly, and then do an oral suction. What I meant was, don't do it blindly. If you have any doubt, don't do it blindly. Even if you don't doubt, don't do it. Ask someone, ask a senior, ask a anesthetist to open the mouth to see whether the blood, whether CSF is coming, whether there is any injury to the base of the skull. And then under laryngoscopic guidance, if you need to put a suction or a rail strip, you just put it down. You can do that way. Just to be careful that it doesn't go inside the brain. That can be catastrophic. That's the reason.
Sir, in craniectomy, do we call it decompressive craniotomy also, or it's a misnomer?
No, decompressive craniotomy, as I told, is just taking out the bone flap, doing a tumor operation, or taking out the blood clot and putting the bone flap back. That's called a craniotomy. In decompressive craniectomy, it is basically operation to prevent very high ICP when all other measures have failed. All the measures of like hyperventilation, mannitol, posturing, ventilation has failed. We take out large flaps. Maybe there's a large flap, and the flap measurement is 15 by 12 centimeters. So the anterior posterior diameter of the flap is 15, and the top to down diameter is about 12. And that huge flap is taken from the frontal, parietal, and region of the bone is taken out. The dura is cut in a crisscross manner. Maybe you do nothing inside the brain just pulsates, and then you don't take the flap, you just put the skin back, scalp back. You take the bone flap, keep it in the abdomen, or keep it in the fridge, or in nowadays in England and other parts, they just throw the flap. And after some time, when maybe 2 or 3 weeks, the brain settles down and the edema settles down, and there is a gap in the brain where actually the skin is found to be going inside, you go do what is called a 3D CT reconstruction, and you do an exactly titanium bone flap. You model it out from the gap in the bone, and you take out the skin again and put the titanium bone material at the level of the bone gap and fix it with screws over the bone. That is called a cranioplasty. Okay, so that's called a cranioplasty. So basically, decompressive craniectomy is basically when you decompress the brain via craniectomy and don't put the bone flap back. Is a life-saving measure for large infarctions, bad head injuries where there's no other way you can control the blood pressure in the brain, and you actually have to take out part of the skull to let the brain expand outside. That's called decompressive craniectomy. And the sizes are anterior posterior is about 15 centimeters and top to down is 12. You should be a large flap, and then patient is on ventilator. 2 or 3 weeks later, when the patient settles down, if the patient survives, you put the bone flap back or you put an artificial material. That's called decompressive craniectomy and the consequent cranioplasty.
I want to ask you, sir, like decompressive craniotomy, it is normal craniotomy only.
Craniectomy. Decompressive, not a craniotomy. Decompressive craniectomy always, because you never put the bone flap back then. It's a craniectomy.
Thank you.
Sir, another indication for surgical decompression or surgical management In subdural hematoma, sir, you said hematoma more than 10 mm. This 10 mm is like the CC or the volume or the length or breadth, sir?
No, 10 ml is there's
10 mm, sir.
Normally there is ways in the CT scan where they can actually measure the ml, but normally what we do is we measure it by the anterior, posterior, the depth and the length. We find out from just measuring it by a tape actually. It is the total volume of the blood. And if you want me to ask how do it, actually they are in the modern CT scan computers, they just strike on there and they can tell you the amount of blood that is collected. But even with a CT scan, you can use simple measures to see the coronals and the sagittal and the axial cut, and you can measure and you can get a rough idea of amount of blood there. So it is not 10 ml. If it is less than 10, we don't operate. But normally
10
about 30
mm, sir. On the slide, it was given like midline shift more than 5 mm, or
yes.
Subdural hematoma more than 10 mm. So
yeah.
it is. So it's not 10 mm, no, sir. Or just
no,
the
not
volume
mm, not mm. It's a volume 10 ml, cc,
ml.
not mm.
Okay,
It is a volume of. I'm sorry. It is not the millimeter. The shift is in millimeters, and the amount of subdural is in ml or cc. You know, cc.
So, sir, SDH more than 10 cc is indication for decompression, sir, or the 30 ml is required for decompression?
No. If actually what I told was below 10, we never do. Between 10 and 30 is a discretion of the doctor to do or not, depending on other parameters, if there's a shift.
Okay, sir.
But
Okay,
if it is above 30, then you do it actually. 30,
okay, sir. Thank you, sir.
50, you do it. Okay.
Okay, sir. Thank you, sir.
Any questions?
Hello, sir.
Yeah.
So,
please.
how much is the chances of recurrent bleeding if we just do a burr hole and extract the blood? So,
Could you just place the question once more, please?
so if we just do a burr hole surgery, so how much is the chances of recurrent bleed in that case? Because we are not clotting the blood vessels.
No. The chances of recurrence is always there in any form of brain surgeries, but you should know that the indication of burr hole surgery is when the fluid inside the brain is totally liquid. Okay, the liquid. If you do a burr hole, you can never take out a chunk of blood from through a burr hole, because if the blood is clotted, you know, any blood which clots, it forms like a jelly, like a curd. You can't take it out. When you know that in the CT scan the blood is absolutely fluid, it has become liquefied, the protein has subsided, it is just the serum. Then you can take it. And the chance of recurrence depends on if the patient is elderly, if the brain is already atrophic, if there's a gap doesn't fill up, then the chance of recurrence is high. It may be about 20-30% recurrence. But if the brain is a young patient's brain, and the moment you take out the blood and the brain actually swells up to the surface of the burr hole, then the chance of recurrence is less. It all depends on the amount of cerebral atrophy that has taken place, whether the patient is elderly. And obviously, recurrence also depends on whether the patient is on any blood thinners like aspirin or warfarin. And if the patient is elderly, if the patient has some diseases, the recurrences do go up. But normally, for normal subdural hematomas, there's a good chance of a recurrence of at least 15 to 20% people do come with a recurrence, because the gap between the subdural space and the brain remains. The brain doesn't swell up, you know, and the gap again refills with blood. The whole idea is that if the brain is atrophic, then the gap doesn't fill up. If the brain is not atrophic, the moment you take out the blood, the brain springs back. It just swells up. You can see in the surgery, it swells up to the undersurface of the dura. There's no gap between the dura and the brain, and so there's no chance of recurrence in that case. Okay.
Sir, in such an atrophic brain who comes with a brain bleed, should we not give mannitol, sir? Because there is already space for the bleeding to occur, and if we give mannitol and shrink the brain more, will the bleeding increase? In such cases, is mannitol contraindicated?
Yeah, but it's not a contraindicated. If there is a bleed in the brain, and if you find there's no increase in pressure in the brain, if there's still atrophy, there's no indication of mannitol. Good question, because the patient, if we give mannitol to reduce the ICP, if the brain is already atrophic and there is a ICH and the brain is not actually creating any pressure effect because the brain is atrophic, then giving mannitol will not be of benefit. Yes, in a way, it might shrink further and it might cause further bleeding. Yeah, it's a good question. That's the discretion of the doctor. But if you find that the pressure is not raised even in spite of the bleed, don't give mannitol. Don't give mannitol.
Sir, so without measuring the ICP or without doing a ventricular catheter, we can't predict, no, sir, the ICP.
ICP, you cannot predict without the
monitoring.
The modern ICP measurements are basically we put a transducer in the brain parenchyma and we can measure the pressure. Without putting the pressure, you cannot actually give a definite idea of ICP. But if you see the CT scan in a raised ICP, if you see a CT scan, the sulci gel in all the systems defects, you can't see the systems, all are compressed. Then from a CT scan, you can get an idea that the ICP is raised. Yes, but the best measure is to put a bolt inside the brain and measure the ICP. And if it is more than 20-25 millimeters of mercury, that is raised ICP. But other than that, from the clinical manifestations from the CT, we can give a rough idea that maybe the ICP is raised. But without the bolt, you can't. Without the ICP monitor, you can't give a definitive answer to a raised ICP. Good question. Good question.
And sir, cysternostomy in raised ICP, sir, how often do you do it, or is it useful?
Cysternostomy.
Yes, sir.
Yeah, cysternostomy in a raised ICP, we don't do it very often, but when we go in and do a decompensative craniectomy, then only. We don't do a cysternostomy normally, but when we go inside the brain and do when we do a decompensative craniectomy, then we go inside the cisterns and bifurcate the cisterns to let CSF flow out. That we do. But just doing a cysternostomy is not effective. You have to go for a decompensative craniectomy. Then you should go to the cisterns and then you should dissect the cisterns to let further CSF flow out. Then we do it. But it's not very effective, because the cisterns are so compressed in a raised ICP that if you do a cysternostomy, it doesn't bring in much, because most of the CSF has been pushed out, because the brain is so in such a high pressure. The CSF is pushed out. The ventricles are all squeezed. So where would you do the cysternostomy? It's all squeezed.
Yes, sir.
There's so much of brain that the CSF has flown out and is out, not in the brain anymore.
So we don't routinely do it, no, sir, right? In craniectomies and all we do.
Craniectomy we do, and if you think sometimes there's a place in the cisterna magna, it's a posterior part. There we try to drain CSF. Sometimes when we go for the Sylvian fissure, but routinely it's not done because in that high pressure, it's very difficult actually to dissect a cistern. And even if you dissect a cistern, in the cistern there are major blood vessels. You can injure the blood vessel. So we don't do it because it's very compressed. What you can do, contrary, you can do an EVD. You can do an external ventricular drain. You can put a drain inside the ventricle and that can come out. That you can do. EVD. So the whole idea of reducing pressure is that you either lower the amount of CSF, lower the amount of blood, or you do take out the clot. Because the pressure in the brain is due to the brain parenchyma, the CSF, and the blood. So whenever there is a huge compression, the CSF and the blood are squeezed already, isn't it? So what you can do is that you can only operate on the skull, take out the skull, and let the brain expand, because there's very little CSF space anyway. It's all squeezed out.
Okay, sir. Thank you, sir.
Okay. Any other questions? Anyone?
Sir, any contraindications for giving mannitol, sir?
Yeah, that's a good question. Contraindication for giving mannitol obviously is, as I think I told you earlier, sometimes when there is an epidural hematoma, we sometimes don't give mannitol because, what happens is that when the brain shrinks further, because the epidural hematoma is outside the brain, it's between the bone and the dura, there's a chance that the epidural hematoma might expand further. So sometimes we don't give in epidural hematoma. That is the contraindication. We don't give mannitol in patients who are hypertensive, cardiac failures, because what mannitol does is that mannitol initially causes hypervolemia. So the patient can have in cardiac issues, it can cause a lot of cardiac problems. And in cases of renal failure, we don't give mannitol because it induces further renal failure. So in epidural hematomas is the neurosurgical cause, and systemic cause of patients who have high hypertension, who have cardiac issues, because hypervolemia happens in them. And if there is issues of renal failure, if the fluid cannot come out, because mannitol ultimately causes diuresis. It causes diuresis, and mannitol itself causes further damage to the renal tubules. So in kidney disease, in heart disease, in hypertension, normally we don't give mannitol, or we give mannitol extremely cautiously, very cautiously.
Thank you, sir.
Okay. Any other questions? Anyone? Anything you want to, any doubts, you can clear it. Or we can clear doubts again when we have classes, maybe on the 4th. All silent.
Hello, sir.
Yes.
Can we,
Sure.
is there any imaging modality to diagnose diffuse axonal injury, sir?
Good question. You have studied neuro. Yes, this MRI question, this is MRI features are there. In diffuse injury, as I told earlier, that if you see a CT scan and the normal CT scan is there and there is the patient is deeply unconscious, then you should suspect diffuse injury. And that is one of the reasons and one of the few cases where an MRI is important in head injury. In others, in subdural, epidural, MRIs have no significance because you can see such well in a CT scan. In diffuse injury, when you do an MRI, there are 3 grades of diffuse injury. You can see cortical changes in the brain parenchyma. That is diffuse injury grade 1. When the injury goes up to the corpus callosum, it's diffuse injury grade 2. And if it goes up to the brainstem, so it is actually injury. If you see there is single changes in the brain parenchyma, only this diffuse injury grade 1. If the injury is in the corpus callosum, it's up to grade 2. And if there is an injury to the brainstem. So there are 3 patients, all the CTs are normal. And then you do an MRI. The person with only injury to the parenchyma has an excellent prognosis, and the person with a brainstem injury has a bad prognosis. So that is the way you can differentiate in a head injury of patients with normal CT. And then you can do an MRI and say to the patient A that he has a good chance because in the MRI it shows only parenchyma injury. To B, injury up to the corpus callosum, he has also a fairly good chance. But if you see a patient has brainstem injury, he has a bad chance. But in the CT, none of them will show up and all will look the same. Very good question. So MRI is an indication, especially to evaluate diffuse injury, because that cannot be seen in a CT scan. It can't be seen like an epidural hematoma or a subdural bleed or ICH. It looks a perfectly normal scan, but in MRI, you will get a perfectly abnormal MRI. You can see it.
Okay.
All right. Is that enough for the day today? Long class.
Yes, sir.
Yes,
Thank you, sir.
Any other? Okay, I think just next class when we'll have, I think it's on the 4th. I think they have scheduled me a class. We'll go over this head injury further. I'll bring in further scans. I'll show you all the type of scans and all the smaller questions that can be asked. And you keep all your questions ready next week, and we'll discuss all the questions. Okay. All the any confusion you have, you just bring it up with me, and we'll decide. Okay, we'll discuss. Okay. Thank you, students. Thank you very much. Okay.
Thank you, sir.
Thank you, sir.
Thank you.